Hello, everyone. My name is Michel Kavera from RBC. I'm the director of epidemiology unit within malaria and other parasitic disease division. Thank you.
Good morning, everyone. Naomi Luki. I'm the CDC PMI resident advisor in Rwanda. Thank you.
Good morning, everyone. I'm Beata Mukarugwiro, working with USAID PMI as the malaria specialist. Thank you.
Good morning, everyone. My name is Caroline Piri Chivawe. I'm coming from Zambia. I work for PATH. I'm chief of party on a PAMO Plus project. It's a malaria project, PMI funded.
Good morning, everyone. I'm Dr. Bumba Dominique, National Malaria Control National Malaria Control Program of Cameroon.
Good morning, everyone. My name is Blaise Fonralenui. I'm from Central African Republic. I work with the Mentor Initiative as country director. Thank you.
Good morning, everyone. My name is Busiku Hamainza. I'm the acting director for the National Malaria Elimination Program in Zambia.
Good morning. My name is Stella Babalola. I'm professor at the School of Public Health, Johns Hopkins University. Thank you.
Bonjour, ici c'est Dr Kodbese Blotigam. Je viens du Tchad, je suis le coordinateur adjoint du programme PALUSA.
Good morning. I'm Anita Kamara, I'm Malaria Case Management Team Lead from Sierra Leone.
Good morning. My name is Jacqueline Munyana. I work at Intra Health as a malaria specialist.
Good morning, everybody. I'm Dr. Ahmedine Omar, the acting head, National Malaria Control Program, Kenya. Also, focal point for case management in Kenya.
Good morning. I'm Dr. Seyna Bougay from NMCP Senegal, and I am team lead for training, case management, and drug-based prevention strategies. Thank you.
Good morning. I am Dr. Odell Kumen from Liberia. I am from the National Malaria Control Program, and I am the acting Deputy Program Manager.
Good morning. I am Ashley Malpass. I am a technical advisor at the U.S. President's Malaria Initiative. Thank you.
Good morning, everyone. I'm Mercia. I'm Mozambican. I'm MNCP program, and I am case management focal point.
Good morning. I apologize because I am a Portuguese speaking. From Angola, Elisa Miguel, Programa Nacional de Control de Malaria.
Bonjour.
Good morning, everyone. I'm Dr. Jaina Chan, Principal Advisor at Malaria Consortium UK, but working out of Uganda.
Good morning, everyone. My name is Samatar Kayat, NMCP Manager, Djibouti.
Good morning, everyone. My name is Gudsa Safa, Acting National Malaria Program Manager of Ethiopia. Thank you.
Good morning. I'm Dr. Chanel Mohoza, Chief of Case Management Unit at NMCP Burundi.
Good morning, everybody. My name is Dr. Prudence Hamadi. I'm a Senior Technical Advisor at the Malaria Consortium based in London.
Good morning. My name is Noela Umulisa. I'm the Chief of Party for PMI Impact Malaria, implemented by JAPAIGO in Rwanda. Thank you.
Good morning. I'm Sosten Lankulani, Case Management Team Lead from Malawi, National Malaria Control Program.
Morning. My name is John Mutali, the Chief of Party for PMI Malaria Project in Malawi. Thank you.
Good morning, everyone. My name is Kate Wolf. I'm a Senior Technical Advisor with JAPAIGO's Malaria team. I also support Impact Malaria and work on the malaria and pregnancy case management. Excuse me, the malaria and pregnancy RBM working group.
Hello, good morning. I'm Peter Olumese. I'm with WHO, Geneva, case management, and also the co-chair of the RBM CRO-SPC.
Good morning, everybody. Gladys Tete, based in the US. I work with JAPAIGO as Senior Director for Malaria.
Good morning, all. My name is Dennis Raika. I head Malaria Case Management, Malaria Control Program, Uganda.
Good morning, everybody. My name is Dr. Nenna Obulafo, and I'm the Head Case Management National Malaria Elimination Program, Nigeria.
Yeah, good morning, all. I'm Dr. Rusasi Abdallah from National Malaria Control Program, Tanzania. I'm Team Lead of Case Management Unit. Thank you.
Bonjour à tous, je suis Armand Diapi, pharmacien, je viens de la Côte d'Ivoire. Je travaille au programme national de lutte contre le paludisme en tant que responsable de la prise en charge.
Good morning. My name is Phyllis Awor. I'm a researcher based in Uganda at Makerere University.
Good morning. My name is Dr. Paul Boateng. I'm with the National Malaria Control Program, Ghana, case management focal person. Thank you.
Good morning. My name is Henk ten Besten. I'm coming from the Netherlands. I'm working for the Medical Expert Group, which is a pharmaceutical wholesale company. And I'm very interested to learn more about malaria these days.
Morning, my name is Nekoye Otsula. I'm the Global Medical Affairs Director for Malaria at Novartis and working out of Nairobi, Kenya.
Good morning, my name is Modest Ariman. I work for JAPAIGO as Impact Malaria Technical Advisor.
Good morning, my name is Akusia Jesse from JAPAIGO, Ghana. I'm the Clinical Advisor. Thank you.
Good morning, everyone. My name is Christian Sanzabana. I'm a group leader at the Swiss Tropical and Public Health Institute.
Good morning, I'm Charlotte Edis. I'm the Deputy Technical Director of the PMI Impact Malaria Project headquarters. I work out of London.
Hello, everyone. My name is Amy Ellis. I'm a Senior Technical Advisor for Health with Catholic Relief Services.
Bonjour à tous. Mon nom c'est Idriss Sabiti. Je suis le coordonnateur adjoint du Programme national de lutte contre le paludisme au Niger. Merci.
Bonjour. My name is Jean-Louis Mangara. I work for the Malaria Division and RBC as Director of Prevention.
Good morning, everyone. My name is Mehul Dorda, and I'm here from the Mahidol Oxford Tropical Medicine Research Unit in Bangkok, Thailand. And I coordinate the DTAC trials in Africa, on which there's going to be a presentation tomorrow. Thanks.
Good morning, I'm Stéphane Duparc, the Chief Medical Officer at Medicine for Malaria Venture, and I'm based in Geneva.
Is that everyone? Have we missed anyone? Good. You would have already met Lena, or from Swiss TPH, who's filling in for Constantina, who unfortunately couldn't make it at the last minute. and also Adam, who is also with the PMI Impact Malaria Project, and they're sitting outside at registration. We are expecting the Minister of Health and other dignitaries to arrive momentarily. I think until they do, we'll take a slight break here. And once the minister arrives, we will resume the program. Okay? Thank you. Just one bit of housekeeping. The restrooms, the toilets are out the door here and to your right. Ladies and gentlemen, the minister has arrived, so if everybody could please take their seats. Okay. All right, thank you. We're reconvening. I'd like to say maramutse to our hosts, and I will introduce Elizabeth Juma, my co-chair, to go through the program for the meeting and do the introductions.
Good morning, dear colleagues. Honorable Minister for Health, Dr. Daniel Ngambinje, the Director General of the Rwanda Biological Center, Professor Claude Muvunyi, Dr. Peter Olumese of the WHO Global Malaria Program, Dr. Corinne Karema, the Interim CEO of the Rollback Malaria Partnership to End Malaria, Dr. Aimable Bituyumremi, the Director of the Malaria Program at the Rwanda Biological Center, my co-chair, Dr. Larry Barrett, of the Impact Malaria Program at PSI, distinguished guests, dear colleagues, good morning. It is an honor and a pleasure to welcome you to this meeting today. And I begin to this case management working group meeting today. The case management working group is one of the Rollback Malaria Partnership working groups. It used to be the youngest. It is no longer the youngest. We've been overtaken by a new lastborn, so we are no longer the baby. But our role really is to meet together as partners to minimize wasteful duplication, synergize our energies, and encourage harmonization, pooling of efforts for faster uptake and scale-up of malaria case management strategies and interventions. So our objectives mirror the functions of the RBM partnership, which is to convene forums such as this one, where we can disseminate guidelines, like from the WHO, share best practices for adaptation and implementation by international and country-level partners. But we not only do that as partners, we also support the scale-up and implementation of policies and strategies, and also coordinate. That is, we try to align and facilitate collaboration between all partners to avoid duplication of efforts, but also to identify challenges and mitigate these by members of the working group. So why do we have this meeting today? You will all agree with me that it's been a while since we have had face-to-face meetings for various reasons. And we, as the case management working group, were the first to be affected by COVID-19. Honorable Minister, we had planned to hold this meeting in Rwanda in February of 2020, but that could not take place because of the prevailing circumstances. Nonetheless, the purpose of this meeting is really for us to share in updates in hot topics in malaria case management. And you will all agree with me that there's quite a lot to discuss. And basically, for us as country representatives and malaria partners, we have partners drawn from private sector, from non-governmental organizations here, research and academic institutions, implementing partners, all gathered here to share experiences on improving malaria case management. So I will give you a brief overview of our agenda. We will start this morning with our brief opening ceremony, and then we will have a keynote address from the Minister for Health for Rwanda, for whom we are really privileged and honored to have amongst our presence. We will then hear an update from the Rwanda Malaria Program, and then we will have a break. And to cap the morning session, we will hear technical updates from WHO, Global Malaria Program, and from the Rollback Malaria Partnership. In the afternoon, we will discuss severe malaria. And there are very good updates and experiences, particularly on community access, but also on quality of care. And then later in the afternoon, we will discuss one of the threats to malaria elimination in Africa, and this is drug resistance, which has emerged in Africa, and we will share our experiences and mitigating. Tomorrow, we have a field trip, as was announced to you, for us to see and hear and learn from the impact of the community case management of malaria in this country. In the afternoon, we will have abstract presentations from selected presenters who offered to share their experiences. And then we will talk about monitoring case management. How do we monitor our progress in case management? What are the indicators? What do we need? And how do we move on? On the last day, we will start the day by discussing the other threat to malaria case management, which affects the rapid diagnostic tests. And this is a parasite mutation that causes deletion of histidine-rich protein 2, which makes the parasite not easily detected by our commonly used RDTs. WHO will share with us what the current situation is and what we can do in terms of surveillance to ensure that we are on top of these threats. And then we shall have closing of the meeting on the third day. So, distinguished guests, ladies and gentlemen, it is now my pleasure to welcome Professor Claude Muvunyi to give his welcome remarks for this meeting. Professor Claude.
Thank you very much, Elizabeth. Good morning, everybody. I think my remarks is going to be very short. So, dear Honorable Minister of Health of Rwanda, dear Interim CEO of Rwanda Rollback Malaria Partnership to End Malaria, dear representative of WHO Global Malaria Program, dear participants, good morning again. As I said, I have only two things to say. The first of all is that I'm really pleased to welcome you in Kigali, in this country of Thousand Hills. And secondly, I also want to really thank Rollback Malaria for hosting this 11th RBM Case Management Working Group meetings. As Elizabeth mentions, we have been waiting for this meeting, and I think this is the right time to really get her in Rwanda and discuss on many issues around case management, which is actually a very important aspect or area in our response to malaria. And also in Rwanda, we have really prioritized the access to the most efficacious malaria treatment as one of the solutions to really respond to malaria. And on top of that, also the access to early diagnostic and treatment in Rwanda is now estimated to be over 95%, thanks to the great work that is being done by the community health workers, and who actually are able to treat more than 60% of reported malaria cases. And I'm sure that tomorrow you'll be able to witness what they are doing on the field during your field visit. So this meeting is very important to us and to all of you, of course, as we are going to really hear presentations on the progress that we have made, and also learn from all countries here present and partners on our achievement in terms of really responding to malaria. But of course, also we do have some challenges. So I think it would be very important to really take our time and discuss on that, and then come up with a good deliberation for this meeting. So without further ado, I'd like to really thank all of you, and I wish you good deliberations, and hope that you also, in addition to this busy week, to also be able to visit Rwanda and enjoy your stay in Rwanda. Thank you very much again. Over to Elizabeth.
Thank you very much, Professor. I would now like to invite Dr. Peter Olumese to give remarks on behalf of the World Health Organization.
Thank you very much. Good morning again, everyone. Honorable Minister, Interim CEO, Corinne, Barry, and indeed, colleagues, it's such a great pleasure to see each other again after such a long time, seeing old faces and new faces. It's been too long. And we, on behalf of the Interim Director of GMP, Dr. Andrea Bosma, who would love to have been here because he is also case management. But of course, he couldn't come. Just want to welcome everyone and to say that, like we know, case management remains a very key and important part of the strategy in terms of reducing morbidity, mortality. And we have very limited arsenal of drugs, and there is the need for us to always come together to ensure that we're using the tools maximally to get all the effects that we can with effective deployment of case management. And I think we are in the best place to hold this meeting, and I look forward to the field trip. There are lots to learn from Rwanda and the health systems and how they deliver case management, because delivery of case management depends a lot on a functional health system. So whenever people say best lessons from Rwanda, I say, well, it's a reflection of the health system. So we're here to learn, and I think this is a great opportunity. I also want to encourage countries, people who here interact, learn from each other. There are lessons to learn, there are lessons to get from one another. So apart from the presentations, and interact in the corridors and get to know what's happening in the various parts in different countries. And lastly, yes, we're discussing case management here, but there is the constant expansion of the use of anti-malaria medicines. The whole field of chemo prevention is expanding, so we also need to bear all of that in mind as we begin to work together. How do we use the very minimal tools we have in terms of drugs? So I look forward to this week and this meeting, and we'll just end by saying welcome, and please have a great time, and I'm sure we would leave here better informed, better equipped to deliver case management. Thank you.
Thank you very much, Dr. Olumese. It is now my pleasure to invite Dr. Corinne Karema, the interim CEO of the RBM Partnership, to give her remarks, and also to invite the minister to give his keynote address. Thank you.
Thank you, Elizabeth. So, Honorable Minister of Health, Dr. Ngamije Daniel, Professor Mambo, DG of RBC, Dr. Peter Olumese, representative of WHO Global Malaria Program, and dear Larry and Elizabeth, the co-chair of the Case Management Working Group, and dear participants, good morning. First of all, I would like to welcome you on behalf of the RBM Partnership to end malaria. And my Honorable Minister, my special thanks goes to the government of Rwanda for offering to host this important meeting, and this just after the excellent concluded Kigali malaria and neglected tropical disease. So I'm not going to talk too much, but my first message is it's really, we are at a momentum in the fight against malaria. So you will see that all the 6 people 5 people who are sitting on this table have been involved in malaria in their early career. So Dr. Daniel Ngamije used to be the director of the National Malaria Control Program, and I replaced him. So he was my predecessor. Dr. Peter, I know him, I think in the 1998, 2000. And Professor Mambo, in his early career, he was also a medical doctor in charge of the test, the drug efficacy study in one of our sites during the monitoring of anti-malaria drugs. So, you know, we used to have ministers, head of institution, in charge and involved in HIV, but I think for us it's really very good, and I'm so proud to see that all the people who are sitting here are malariologists. So this is number one, and I think that we should applaud for that. So RBM, we are here to support countries to focus on addressing the implementation of bottlenecks. And one of our ways is to have platform, collaborating platform. And Elizabeth said it well. So we are here to coordinate partners for them to support countries. And of course, what is very important for us is the country ownership, country involvement, and really putting countries on the table of decision. So our aim, especially for the case management, is to achieve consensus, as well as to look at all the complex strategic issues that are concerning the scaling up of implementation of case management. So it's really good that to see today in our first in-person meeting after the COVID period. So it's really good to see people here. You are going to discuss and then talk about the challenges of implementation, learn the best practices from other countries, and then also learn. And really it's create a very important platform for us to advance and achieve our goal of the RBM partnership to end malaria. So it's really important for us to, this forum, it's really important for us as we are going to have all the stakeholders sitting together and to ensure that our response are a result of combining efforts. So with that, Honorable Minister, I would like to welcome you for your wisdom and opening this meeting. Thank you so much.
The DG of RBC, Professor Claude, Dr. Peter Olmese, representing WHO Global Malaria Program, Dr. Corinne Karema, Interim CEO of RBM Partnership, Dr. Larry Butt, Dr. Elizabeth, my friends, members of Malaria Case Management Group, partners in global and national malaria response, distinguished ladies and gentlemen, good morning. You know, there are meetings I can't miss. Malaria meeting, I can't miss it. At one point, I feared that Dr. Corinne was going to say, if you want to be a minister, just be in love of malaria. But she said the truth. I'm interested with malaria since, 2005, I think, as I worked as a National Malaria Control Program coordinator. And then later on, I was grant manager for malaria grants for 10 years. Then project officer, WHO office country, yeah. So I was around malaria for long, so it's my pleasure, I can't miss this kind of meeting. So it is my great honor to welcome you in Rwanda for this 11th meeting of RBM Partnership Case Management Working Group meeting. I also extend a warm welcome to representative of 20 national malaria programs from Africa here present for this meeting, which we are glad to host in Rwanda. I thank the RBM Partnership to End Malaria and you all for organizing this meeting aimed at sharing experiences, learning, and collaboration to improve malaria case management. The theme for this meeting, access to quality care and mitigating anti-malaria drug resistance, are both critical in ensuring no one dies from malaria. Despite different and combined efforts for malaria control, this disease unfortunately continues to represent a public health threat globally, and particularly in Africa, where cases increasing since 2017, indicating a reversal of progress made since the year 2000. WHO latest World Malaria Report released in December 2021 shows that there were an estimate 241 million cases and 677,000 malaria deaths worldwide in 2020. This represents 14 million more cases in 2020 compared to 2019, and 69,000 more deaths. Approximately 2/3 of these additional deaths were linked to disruption in the provision of malaria prevention, diagnosis, and treatment during COVID-19 pandemic. In Rwanda, where we were about to eliminate malaria in 2011, we faced the same malaria upsurge from 2014, with a peak around 5 million cases in the fiscal year 2016-2017, just at the beginning of the Global Technical Strategy, GTS 2015. From 2017, Rwanda made remarkable progress following sustained malaria control interventions and multi-sectoral collaboration approach with focus on community case management by community health workers. Key results include a reduction in malaria from 4.8 million in 2016 to 1.1 million in 2021. A reduction in severe malaria cases from 18,000 in 2016 to 1,900 in 2021, and a reduction in death due to malaria from 700 deaths in 2016 to 69 deaths in 2021. For the success of our programs, we need to focus on the following: skilled health workforce, community participation, engagement, empowerment in malaria control, and regular surveillance for drug efficacy to detect and mitigate anti-malaria drug resistance, and intersectoral collaboration. In addition, we must strengthen cross-border collaboration and coordinated approaches for the implementation of intervention to achieve malaria elimination. With the required financing, strong coordination, dedicated partners, and engaged communities, we can achieve our vision of malaria-free Africa. Let me use this opportunity to once again thank RBM Partnership and all of you for organizing this meeting and choosing Rwanda as host. I wish fruitful discussion. Thank you so much.
Thank you very much, Honorable Minister, for those opening remarks and for the challenge that you have thrown us at this meeting. Now I would like to invite you, seated at the high table, to come to the table down so that we can hear from Dr. Aimable Bituyu Muremi. Today I got your name right. To give us a brief on how Rwanda is making this progress towards malaria elimination. Dear colleagues, we want to remind us that malaria, the progress towards elimination, is a continuum. It is not dichotomous. There is no control and elimination. It is a continuum that progresses towards elimination. So let us all keep the goal, the vision in mind. Welcome, Dr. Aimable.
Honorable Minister, dear partners in malaria response at global and national level, good morning once again. Yeah, it's my pleasure to share with you this morning the country progress toward malaria elimination, considering the last 5 years' achievement, whereby, as the Honorable Minister said, we have faced an upsurge for malaria in 2016. I will be sharing with you a few slides to show key program indicators, but I'll start with this slide, where you can see that the health sector structure is set in this way, where we see that from community level, we have around 60,000 community health workers who are dedicated to provide essential services, including malaria package. And currently, we have around 30,000 community health workers fully dedicated to malaria management at community level. The second level is a health post. This is almost a new structure, supporting community health workers before people reach health facilities up level. The third layer is health centers. And currently, in each sector of Rwanda, we have at least one health center. And these are run by nurses, but also we have lab technicians who can also provide diagnosis and treatment. For hospitals, we currently have what we call district hospitals. And within our 30 administrative districts, at least we have one hospital, which is run by a medical doctor. But of course, we have many medical doctors, including lab technicians and nurses as well. And they can receive just few cases of malaria, including severe cases and pregnant women. The upper level is about provincial and referral hospitals, where we have specialists. And of course, these are meant to receive advanced disease of malaria, where they can provide advanced treatment. And in summary, currently, we have at least almost all simple malaria cases supposed to be managed by either community health workers or health facilities, including health posts and health centers. Only severe malaria should be going at the hospital level. And you can understand that currently, there is early diagnosis and treatment, and we see the good result. As per the national strategic plan now, the one we have is of 2020-2024. The main goal is to reduce malaria burden, including mortality and morbidity, by 50% by 2024, considering the levels of 2019. Now we'll be sharing with you the progress made so far from 2020, when we started implementing the current strategic plan. Here's the list of key malaria control interventions currently in place in Rwanda. Number one is about malaria prevention. And you can see that this is mainly focusing on distribution bed net through different channels. The main channel is routine distribution, whereby health centers are giving net to pregnant women and under 5 to ensure that those two groups are well protected. The second channel is through mass campaign. Currently, we organize it every 2 to 3 years, and the last campaign was done in 2020, and currently we are starting a new campaign extending up to 2023. We have, of course, other small channels where we target like schools, targeting hospitals, facilities, but also refugee camps and prisons. And the second intervention, which is very key, is indoor spraying. This is currently deployed in 12 districts, mainly eastern part of the country. We have sprayed 7 districts, and also 5 districts of southern province. Those 12 districts have been representing around 75% of all malaria burden in 2016. And you can understand why we need to spray there, because data shows that IRS has high impact in reducing malaria incidence. Of course, we have some targeted IRS in some sectors out of those 12 districts based on data to address malaria upsurge. Another intervention is around malaria case management, and this is in line with our meeting today. Case management currently is implemented at different levels, but level 1 is community level, where we have in each village 2 community health workers. One is a lady, another is a male, and they are called binom, managing both malaria, but also pneumonia and diarrhea for under 5. But for malaria, it's for all ages, and this is countrywide. Another level of case management is health facilities, as I presented through that initial slide, health posts, health centers, and hospitals. And of course, we are trying to make sure that almost all cases are managed by community health workers. And currently, we are happy to announce that around 60% of all malaria cases are managed by community health workers. SBCC is a very key and cross-cutting to support all other interventions so that we increase the awareness to make sure that people know where services are found and also to make sure that they access to them on time. And we are supported with local NGOs, but also local leaders, as well as community health workers and media, of course. They are supporting for SBCC. Surveillance is very key, and all the data we are using are coming from all over the country, from the village level up to hospital level. We are collecting data on a monthly basis, and these data are the ones informing our program. Of course, for IRS case management, we have also other surveillance aspects where we conduct on a regular basis therapeutic efficacy studies to inform our case management programming. And of course, for IRS and bednet deployment, we do routine surveillance of insecticide resistance to see if really our products are working well. Lastly, it's a new introduction of tools. Recently, you could see that sustaining our IRS and bednet indoors, we are creating mosquitoes that are biting outside. And this is a challenge that is only meant to be addressed by new tools. That's why recently we started addressing those mosquito biting outside through the use of mosquito repellent, but also live siding to make sure that we reach mosquitoes at their early stage in Rwanda. This is how we deploy interventions based on data we are collecting. As you can see from this map, this block in brown corresponds to the areas of IRS, and you can see that we have documented pyrethroid resistance, where you can see those red dots. These red dots correspond to mosquito resistant to pyrethroid. And you can understand that deploying standard nets would be a waste of money, but also no impact. And those green zones correspond to water bodies, and you can see water bodies. And this is also showing that we need to collaborate beyond Ministry of Health, and we are engaging local leaders, Ministry of Agriculture and rice farmers to ensure that they support in the malaria response as well. From 2018 now, all those 12 districts have been spread consistently, and we have a good result. For the block in yellow, it's where we deploy a new generation of bed net. Because we have also documented resistant to pyrethroid, you can see those red dots as well, but found were not available to deploy IRS as well. And using those data, we convinced Global Fund and USAID to provide PBONet and G2Net that are deployed in those 9 districts, where also we have some high endemic districts but if we had means for IRS, we would have deployed IRS as well. The last block is in pink. It's where mainly we have no resistance at all, and we have also low burden of malaria, and deploying standard net is not really an issue for us. This is how we deploy malaria intervention for prevention based on data to ensure that we use efficiency. Now the next part is about key malaria program indicators, and these are key achievements vis-a-vis our national target. As I said, our goal is to reduce by 50% malaria morbidity and mortality by 2024, considering the baseline of 2019. Now, indicator number 1 is about malaria cases. And you can see in red, it's where we have the baseline of our national strategic plan. And maybe you can see that in 2024-2015, there was a progressive increase in malaria cases, reaching the peak of around 5 million in 2016, when now the government put in place malaria contingency plan, involving all key ministries to ensure that we combine all our effort in malaria response, beyond the Ministry of Health only. And you can see that so far from 2020, we have made good progress and have reduced up to 63% reduction in malaria cases compared to the baseline of 2019. While the target is 50% by 2024, you can see that we have already achieved the target of 2024 within 2 years, following a sustained intervention for prevention. And of course, we are planning to review our strategic plan very soon, from September to December, with the support from WHO expert, and we may recommend additional interventions and set a new target. The second indicator is about severe malaria. Those people who delay getting services, they may go into severe case stages, and we need advanced clinical service. The same as from the opening remarks from the Honorable Minister, in 2016, there was that total severe malaria cases around 17,000, and in the baseline we have in red, it's around 7,000 severe cases, and the drop is almost the same, 63% in the first 2 years of our NSP, and I think it's a good progress, and this only translates the effort of community health workers and health centers who are managing all simple malaria cases on time before they progress into severe cases. For death due to malaria, this is very key. And of course, from the baseline, we see that decrease around 65% reduction, what is also good. And of course, no one should be dying from malaria once we have commodities at community level at your door. No one should be dying from malaria now in Rwanda. And we need to put more effort to ensure that using local leaders, local NGOs, all people should be treated on time. When you consider the level of service provisions, we can see that in the blue, it's where cases are managed by community health workers. And from 2014-15, only under 5 were managed by community health workers. But following the upsurge of 2015-16, the cabinet approved extending HBM in all ages and free of charge for category 1 and 2, those who are poor and not able to afford services. And you see this increase in proportion, currently around 57 last year, and now 50%. And this has a justification, this drop, because now we are increasing the number of health posts as another layer that is absorbing severe and simple malaria cases. For the incidence, this is very key, And from this peak of 2016, with around 400 per thousand as incidents nationwide, there is a drop up to only 86 per thousand. What is also a good progress, but we are not yet there with elimination. When you compare data per province, I think this is very key to know where we can sustain interventions. You can see that with the data of 2021, from January to December, with this total of around 1 million, most of cases were coming from south, then east. And those are the high endemic zones, and they are putting all our effort to ensure that we address malaria properly. And the same for incidence. You see that also the most affected district is south, with average incidence beyond the national one. And now we need to put more effort and sustain IRS and deploying new types of net and adding new tools as well. It's the same with the severe cases. We use data to deploy key interventions based on data, and we monitor impact after a given period to see the progress. Community-based surveillance is a new tool. We are putting more effort in it, and we have now trained local leaders. We have trained rice farmers. We have trained also community health workers and other key groups to ensure that they also help the central level surveilling the disease, because all mosquitoes are coming from the village level. And this is a team we have trained at community level, and they are very supportive, and you can see that they are trying to detect breeding site in rice plantation areas. And this is informing us to deploy either live siding or any other live source management. Data use for programming is very key. As we share our experience, you can see that we have used resistant data, but also incidence data to deploy either IRS or new types of nets. Imagine if we had deployed our G2 net in northern province. We could see maybe a small impact, but no response on malaria issue in Rwanda. But using resistant data and incidence data, we are deploying our intervention appropriately. And this is a new deployment plan for 2022 as organized a new mass campaign. And you can see that we have kept IRS in all those districts in the red dot. And now we are increasing the number of PBONet. Because preliminary data we have on PBONet use, they are really effective. And the cost now is affordable. That's now we are increasing the number of new types of net districts from 9 to around 15 now. And we hope to get more results. And only those 3 districts will be kept under standard net. Where are we with elimination now? I think this is a key question and challenging for us, because as you can see, we have those mosquito resistance, we have those water bodies, and I think with the current interventions, we may not eliminate malaria in Rwanda. That's why we need to use data at the lowest level, up to sector level, cell level, why not village level, to ensure that we address malaria properly. And you can see this big change. This was in 2016. All sectors in the dark were representing more than 450 per thousand. Even some of them could reach more than 1,000 per thousand. And you can imagine that people could have like 5 or 3 episodes of malaria per year. But with the sustained interventions, you can see that almost the entire country is in yellow, with below 100 per thousand, meaning that we have a good progress, and almost those zones in yellow are prone to pre-elimination. And happy that we have WHO with us. You'll be helping us the next few months to design new interventions to address malaria. And you can see we still have some hotspot within those IRS districts. We still have few sectors We don't know what is happening there. We need community-based surveillance and deploy new interventions. I think to make sure that we eliminate malaria in Rwanda and have zero malaria, start with me and with everyone here, we need to address those malaria hotspots where they are. We need to sustain interventions, but also need to introduce new tools. We need to engage all stakeholders, and strong surveillance is very key, and going beyond sector-level surveillance, but going up to village level to see how we can make change. We need also a response at community level, not waiting for the central level to respond. It's better to get a local response based on local data. As we respond from the central level, there is a delay, and sometimes we are missing the real response. And digitalization of community health services is very key, because currently we are only receiving data from health centers and we are missing the lowest level. Now, with the Ministry of Health effort, with support from Global Fund, different partners, USAID, we are now digitalizing all community package and hope that we'll be having real-time data and real-time response to make sure that we eliminate malaria in Rwanda. I think, lastly, it's about, probably some of you may not know that, but we have some vulnerable groups that we are missing with our core interventions. We are deploying good bed net, we are spraying inside, but rice farmers, security staff are staying outside. Female sex workers are staying outside. Mobile population are not protected with bed net. And if we do not address them properly, we may not eliminate malaria in Rwanda. And this is the ongoing effort to map all those vulnerable groups that we are missing with our existing interventions. Those are mining sites. Those small yellow dots correspond to mining site. And those are not only at risk, but also they can respond. They can help the central level to respond to malaria hotspot, because water bodies are there. Rice plantation areas, you can see them all over the country, but also we see refugee camps, we see prisons, and we see those roads corresponding to truck drivers, mobile population, cross-border issues, and we need to put more effort if we need really to eliminate malaria in Rwanda. With this, I think I would like to thank you so much for your attention, and if there's any question, feel free to ask. Thank you.
Dear colleagues, I think you will agree with me that that was very insightful. And we have been thrown the challenge, including, I think Aimable has ably answered his question, what we need to do, reaching everyone, identifying populations at risk, stratification, tailoring interventions, using data for decision making. I think all these we will learn more and we will speak to and share experiences as we go forward. Ladies and gentlemen, we have come to the end of the opening session for this morning, and we are going to take a group photo before we have our break and let our distinguished guests also stay on or depart at their leisure. The group photo will be taken outside the hall, just on the doors to the right. There are stairs. We will all stand and head there, and then we will head on to break. Larry?
Yeah, no, just a moment of personal privilege. I need to beg forgiveness from Dr. Karine and Dr. Daniel. This package found its way.
You'll need to turn off airplane mode.
This package found its way into my luggage back in 2006, and it has sat on my desk since that time. For those who don't know, this is Primo. This is Coartem. with packaging that's written in Kinyarwanda. And it was the first, if I believe, the first ACT in Africa to be provided by community health workers. Rwanda has been an innovator in malaria case management, and Dr. Daniel and Dr. Karine, in their respective roles as MOPD director, were the brains behind this initiative. And we very much appreciate you taking the risk. This was a very brave decision at the time. There were a lot of people saying that community health workers shouldn't be prescribing ACTs, but we are all the better for Rwanda taking the risk. So I want to thank you for it. And with that, we'll adjourn to the for the photo and our coffee break.
Colleagues, please have your tea, please have your break. We resume in 15 minutes.
Okay, we're going to get started in about 1 minute.
Chairing this session, it's
Yeah,
you,
it's
eh?
me.
Okay,
Yeah.
perfect.
Oh, yeah.
Go ahead. No, this is fine. It might confuse you, sorry.
Okay. All right, we're going to resume the second morning session. And I'd like to invite Dr. Peter Olamezi from the WHO Global Malaria Program to give all of us an update on the latest guidance and guidelines from the World Health Organization on malaria case management. So Peter, over to you.
Thank you very much, Larry. Good morning again, everyone. And just have a few slides to share. It's technical updates from the GMP. Okay, I have titled it, since this is case management working group, I felt the technical update you wanted to hear about is case management, not indoor residual spraying and larviciding. But I felt it was also necessary to go a little bit beyond just case management and look at recommendations around use of anti-malaria, because it has implications for case management also, as that is expanding. So it's case management and other use of anti-malaria medicine. So I'll speak a bit about chemo prevention and some of the new recommendations that have been released. Again, just setting the picture, we know all of this. Malaria remains a problem here in this part of the world. And from the World Malaria Report, we know what our goal and vision is. I always like to put this up because we should keep focused on what our vision and our goals are. You know, when Emeb was presenting the Rwanda situation, and the last slide that he showed hotspots. For me, once I see hotspots, I say, well, that means you're saying there are cold spots. And he demonstrated it very clearly. They did not become cold spots accidentally. They became cold spots because of the interventions that were deployed there. And so as we aim to tackle hotspots, we need to remember to continue to deploy interventions in those cold spots. Otherwise, they become hotspots. That's the story of malaria. And so we always have to look at the bigger picture in going forward. So these, the global technical strategies and our goals, and like we know, we are off track and we are trying to get back on track. And this was what led to some of the initiatives, the high burden to high impact. And the whole idea was not, it was more of an approach, trying to put in a more structured way what countries and programs we're already doing in thinking about how we effectively tackle malaria. And there were 4 pillars, and what I'm speaking to today, it's more in the better guidance, which is pillar 3, and case management is a part of that. I updated this slide, giving a sort of snapshot of the interventions that we have. And everything I have highlighted in yellow are the new recommendations that have just been released. WHO updated the malaria guidelines recommendations about 3 weeks ago, 4th of June. So those areas are highlighted, and quite a lot of them have to do with the use of anti-malaria medicines amongst the areas where recommendations have been made. I referred a short while to the WHO guidelines for malaria. You would not hear malaria treatment guidelines anymore or vector control guidelines anymore. We now just have one guidelines. And in that guidelines, you have the different sections. Sections on prevention, sections on treatment, and elimination. And that was released in 2021. So the case management guideline was migrated into that document. The 2015 third edition case management guideline was migrated into that document. And like I mentioned a short while ago, the latest update was 3rd June. And we continue to update these as more areas come up that require updates. So case management, diagnosis, prompt effective treatment, and the supportive interventions for effective case management, and monitoring resistance of anti-malaria medicines, pharmacovigilance, surveillance, they are all key components of effective malaria case management, not just diagnosis and given anti-malaria medicines. The recommendation for diagnosis remains unchanged, that all suspected malaria cases should have a parasitological test either microscopy or rapid diagnostic tests to confirm diagnosis before treatment. And it's so important that we have a robust and effective quality assurance program in place to ensure that the diagnostics and diagnosis that we are undertaking is of acceptable quality. And in that way, the health workers can continue to rely and trust the results of the diagnostics and the diagnosis they are undertaking. However, in situations where these are not readily available and treatment can be initiated based on clinical suspicion. But this should be minimal as diagnosis has been scaled up almost everywhere, including at the community level. The treatment of uncomplicated falciparum malaria, children and adults with uncomplicated pre-falciparum malaria, excluding pregnant women in the first trimester with an ACT. I've highlighted excluding pregnant women in the first trimester because currently in the area of case management, that is being updated. We've had all the meetings and we've submitted, and hopefully in the next couple of months maximally, we would have an updated recommendation in terms of treatment in the first trimester of pregnancy. And currently the ACT is recommended still remains the artemether lumefantrine, artesunate amiodarquine, artesunate mefloquine, DHA piperaquine, artesunate sulfadoxine pyrimethamine. Artesunate pyronidine is also among the ongoing revision of the guidelines. In terms of reducing transmissibility of P. falciparum infection, the use of a low dose, single dose, 0.25 milligrams per kilogram body weight of primaquine, along with ACT to patients with P. falciparum malaria is recommended. Of course, exclusion would include pregnant women and women breastfeeding infants aged less than 6 months of age. The whole idea of this is to reduce transmission for its anti-gametocidal activity. But this is recommended for use in areas where you're going towards elimination or areas with very low malaria transmission. In special populations, I've spoken to the pregnant women in the first trimester a short while ago. This is currently under review. Infants weighing less than 5 kilograms use an ACT. In people with HIV/AIDS, you use an ACT. However, you want to avoid artesunate plus sulfadoxine pyrimethamine. And treat travelers returning to non-endemic settings with uncomplicated falciparum malaria with an ACT. For these, what to bear in mind is it's the ACT in use where they are coming from, because they got the infection where they are coming from, not where they are currently. So there's no point using an ACT which is not effective where they are if that's not, or if it is not effective where they are coming from. So we always need to bear that in mind, that use an ACT that is effective based on where they got infected. For uncomplicated non-falciparum malaria, recommendation ACTs or chloroquine. Again, once we review the treatment in the first trimester of pregnancy, that would also be applicable here. In areas with chloroquine resistance, the ACT is the recommended treatment. GCSPD status of patients should be used to guide the administration of primaquine for relapse prevention. Maybe I take a step back. For effective treatment of P. vivax or P. ovale malaria, you require both the primary anti-malaria treatment and the anti-relapse treatment. So the question should not be, should we use primaquine? The question should be, how can we administer primaquine in a safe way? So GCSPD is not meant status is not met as an exclusion criteria. However, it's to be used to guide how primaquine can effectively and safely be administered. And where status is unknown and GCP is not available, the decision to prescribe primaquine must be based on an assessment of the risk and benefit of treating versus not treating. There are risks involved with not treating, and when you keep having subsequent relapses. So to prevent further relapse, we treat people with Vivax or Valley malaria with a 14-day course of between 0.25 to 0.5 milligrams per kilogram body weight daily of primaquine in all transmission settings. I have 14 with a 14-day course highlighted because part of the ongoing revision or update of the guideline is looking at the possibility of administering this same dose over a shorter period of time. So rather than 14 days, administering it over a 7-day period. When it comes to anti-relapse treatment, the most important factor is the total dose of primaquine given. So if it were possible, if it were tolerable, if not for the adverse effects of primaquine, we could actually have used primaquine as a single daily dose. Total dose is what is important. However, because of safety, because of tolerability, that's why we have those prolonged 14-day treatment. So there's the ongoing review of looking at a shorter standard dose. So rather than 0.25 milligrams daily for 14 days, can we give 0.5 milligrams daily for 7 days? Or rather than 0.5 milligrams daily for 14 days, can you give 1 gram daily for 7 days? So that's part of what's in the ongoing review, which should be finalized in a couple of months maximum. I'm saying a couple of months. I'm not saying next month because we are coming into summer. And in summer, like you know, in Europe, almost everything goes on holidays. And so meetings that happen every month, statutory meetings every month. Usually there is no meeting in August for such committees because we are all on holidays. Severe malaria therapeutic objective is to prevent the patient from dying, and death from severe malaria occurs within hours of onset of symptoms or admission to hospital. So it's essential that therapeutic concentration of a highly effective anti-malaria medicine is achieved as soon as possible. There are basically 4 aspects. You have the clinical assessment of the patient, specific anti-malaria treatment, additional treatment, that's management of other complications, and supportive care. These, they are also important. So it's not just the anti-malaria treatment. So it's important that a patient with severe malaria gets treatment in as high level facility as possible. Because you might give the anti-malaria treatment and the patient may require a blood transfusion. You might give the anti-malaria treatment and the patient has problems with renal insufficiency and you need a dialysis. So as high level in the health system as possible, that would be the ideal situation and place to manage a patient with severe malaria. This has not changed in terms of the treatment. All patients with severe malaria, including all infants, pregnant women in all trimesters, with intravenous or intramuscular artesunate for at least 24 hours, and until the patient is able to tolerate oral medication. Then after the 24-hour parenteral treatment, and once they are able to tolerate oral medication, you complete the treatment with 3 days course of an ACT. I guess ask the questions in countries from time to time. If we have used 5 days artesunate before the patient is able to, injectable artesunate before the patient is able to tolerate, do I still need to give a complete course of the ACT? Yes, give the complete course of the ACT whenever you stop the intravenous or intramuscular artesunate. Children weighing less than 20 kilograms should receive a higher dose. That's 3 milligrams per kilogram body weight per dose. If artesunate is not available, use artemeter in preference to quinine. As much as possible, we want you to remove quinine from your the drugs that you use. The artemisinin are the preferred option, and we should ensure that we have artemisinin stocked, artesunate preferably, for management of severe malaria. In settings where complete treatment of severe malaria is not possible and injections are available, children and adults, you want to give pre-referral treatment with single dose of intramuscular artesunate and refer to a facility for further care. So when it comes to pre-referral treatment, we want to give the pre-referral treatment and refer the patient. So it's a combination of both. We want to have a system in place where patients can be sent and referred to centers where treatment would be completed. However, in lower level levels of care at the community level and places where injections are not either available or cannot be administered, it's recommended to use the rectal artesunate and refer immediately to an appropriate facility for further care. Where referral is not possible, which we know exists, and in reality this happens, the pre-referral medication should be continued until the patient can tolerate oral medication, then administer a complete course of an effective ACT. So that's the management of severe malaria. I am aware some of what we must all have seen an information note that came out from GMP sometime last year, early, or was it this year? This year, January this year, with regards to rectal artesunate following the Karama study. That's an information note. The guideline has not changed. The guideline supersedes any information note. Anything that is not guideline, any release information note should be interpreted in the context of the guidelines. So the context of the guideline is pre-referral treatment and referral. And so we want to encourage countries to continue to deploy rectal artesunate as needed and necessary, while working to strengthen your health system to ensure that referral system is robust, and not just the referral system, because in some settings, the community level treatment is more robust than the first level of care you are referring the patient to, which we shouldn't be. The community health worker should not be more stocked with ACT than the primary health level you are referring the patient to. So those three things must be put in place. The pre-referral treatment should be given as soon as possible, refer the patient to the next level of care as soon as possible, and there should be the needed materials in terms of treatments at that level of care for the patient once they are referred. So I hope I have addressed the issue of that information note so that I don't get asked. So I'm dealing with it up front. It should be interpreted in the context of the guidelines, and we should actually use that as an advocacy tool to work with our various governments and ministries that we need to strengthen the community delivery platform, which includes the whole continuum of care to the next level of care and subsequently thereafter. Yep, that leads me straight to community case management of malaria. And I think the Rwanda presentation laid credence to this. Trained community health providers should be provided with rapid diagnostic tests. The ACT is required, the necessary treatment, rectal artesunate, suppositories or pre-referral treatment. They should be able to collect data and tool which should feed into the overall health system. We should begin to see them as part of the health system and not just volunteers working out there. And they should be remunerated. They we should move away from the era of voluntary workers. I don't work voluntarily. Even when I go to supervise them or visit them at the community, I get paid a per diem to go and see them on top of my salary, yet I want them to work voluntarily. It doesn't work that way. And so we need to begin to speak to that. They are a critical part. Sorry, it might look like a deviation, but when Rwanda presented, we were very clear. 90% of the case management is happening at that level from the health facility down. And 60% of the case management, malaria case management, is being done by community health workers. They should be paid and remunerated for what they do because they are a critical part of the system. Back to my presentation. Reviews and other issues in the pipeline. I've spoken to these. Currently, we are working on reviews looking at treatment in the first trimester of pregnancy with the use of ACTs, the use of artesunate pulmonaridine in the treatment of malaria, and the shorter course 7-day treatment of standard and high-dose anti-relapse primaquine treatment. Tafenoquine is not in the pipeline yet, but it would soon be in the pipeline. So it's things we are looking to, and we hope to start the process before the end of this year. Of course, malaria diagnosis, GCSPD quantitative point of care test, which is very linked to the tafenoquine review. So I want to very quickly look at malaria prevention and look at the chemo prevention, because here we're using full treatment doses of anti-malaria medicines we are using for treatment, but rather than for treatment, we are using as chemo prevention. But it also has implications for case management, because we say you shouldn't use the same drug you are using for case management for chemo prevention. And so they speak to each other. The thing to highlight is that in the updated recommendations on chemo prevention, there have been a shift in approach. They provides greater flexibility to national malaria programs to adapt control strategies to suit their settings. The recommendations no longer specify strict age groups, transmission intensity thresholds, number of cycles, or which drugs to use. And the programs are encouraged to consider local data to determine how best to tailor chemo prevention strategies to local needs and determine which age groups should be targeted, where, for how long, what frequency, and which drug to use. First is intermittent preventive treatment in pregnancy. Not much has changed there. Main change here is, if you look at the bullet points, the 4th bullet point where it says ANC contact remains an important platform for delivering IPTP, but where inequities in ANC services and reach exist, other delivery methods such as use of community health workers. So it's, as it were, opening up delivery of IPTP through the community platform. But the only drug we have for that still remains SP. Perennial malaria chemo prevention, which is an expansion of the former IPTI. So in areas of moderate to high perennial malaria transmission, children belonging to age groups at high risk of severe malaria can be given anti-malaria medicines at predefined intervals to reduce disease burden. So again, like I indicated a short while ago, the age groups are not specified, the anti-malaria medicines not specified, the intervals not specified. But what we have currently is the use of SP in the first year of life at 3, 4, and 9 months, and that's the IPTI. This allows and gives room for expanded use and guidance on that expanded use and how that should be done is something in the works. Seasonal malaria chemo prevention, areas of seasonal malaria transmission, children belonging to age groups at high risk of severe malaria should be given anti-malaria medicines not defined during peak malaria transmission seasons to reduce disease burden. Currently, what we have is the use of sulfadoxine pyrimethamine and amodiaquine in children under 5 years of age in a maximum of 4 or 5 cycles. I would come back to these later on, I think at the end. Intermittent preventive treatment in school-age children, which is given anti-malaria treatment to children living in malaria endemic settings with moderate to high perennial and seasonal transmission, full and therapeutic course of anti-malaria medicines at predetermined times as chemoprevention to reduce disease burden. And lastly, post-discharge malaria chemoprevention, as children admitted to hospital with severe anemia living in settings with moderate to high malaria transmission should be given a full therapeutic course of anti-malaria medicine at predetermined times following discharge from hospital to reduce readmission and death. Having said all of that, this slide summarizes where we are with those recommendations. The IPTP at community level, a new feed manual is under development. There was a meeting last week where, using the experience of the TIP-TOP project and countries that are already deploying IPTP at community level to guide in developing an implementation feed guide to help countries in moving forward in that direction. For the PMC, perennial malaria chemoprevention, we currently have an implementation guide for IPTI. And in that guide, you have guidance on adoption and adaptation of that strategy at country level. So that remains valid. However, there is the IPTI Plus consortium, I'll call it, that are working and have pilots underway to inform on how best to expand IPTI beyond the current recommendation and to transition it into PMC. So once these studies are over and the lessons have been learned, how do you deploy IPTI beyond the EPI program into the second year of life, into the third year of life, how many cycles? That would guide in developing an implementation guidance document that would help countries adopt the policy. So those studies are ongoing. So for now, we have the IPTI guidance document, which remains. The same applies to SMC. SMC, there's an implementation feed guide that gives parameters based on the evidence available. And before the end of the year, we intend to update that feed guide to reflect some of the newer aspects of the recommendation based on evidence available. As for the IPT, school children, and post-discharge malaria chemoprevention, we have no guidance documents on adaptation and implementation, and those will be developed subsequently. Because we need to define how many doses, what drug you're talking about, how soon you give it, when you don't give it, how many cycles, all of those need to be determined to guide countries in adapting and adopting and moving forward with those recommendations. And I think this is my last slide. I just wanted to speak to this also. There are some recommendations on mass drug administration, again, which has to do with the use of anti-malaria medicines. And here, what we should watch out for, I just summarized it all on one table, is that there are some recommendations for and some recommendations against. There are, in areas of moderate to high transmission, there are recommendations against the use of MDA as a tool for transmission reduction. However, MDA can be used in specific situations for burden reduction. So it's the indication that determines whether it is for or whether it's against. So all the recommendations against have to do with reduction or as a strategy to reduce transmission, rather as a tool that can be deployed in specific situations, in the circumstances, to reduce burden. Albeit that reduction of burden is usually for a very short period of time. And there's a whole tranche of recommendations on malaria elimination guidelines. Again, I just featured it here because it involves the use of anti-malaria medicines in full treatment courses. And that would include targeted drug administration to reduce malaria transmission, mass drug administration, testing and treatment at various levels. Some are for, some are against. But these are essentially recommendations that have always been, but have been structured and put in a more logical format. So I think with that, just to remind us what the goal is, we are doing all of this to reduce and ensure to have a malaria-free world, and it's a package of interventions. Though I have spoken to case management here, things, vector control and all are all part of the package, and they are all reflected in the WHO guidelines for malaria. So thank you very much, and I will take questions, if any.
Okay. Thank you, Peter. We have about 10 minutes for questions now. We'll also have some time for Q&A after the next presentation for both presenters. So if there are any questions, Peter? Okay.
Yes, thank you so much for a good presentation. I'm Michael from Malawi. My question is on the ongoing reviews on ACTs in first trimester. I know you've just published the consolidated guidelines in 2021, and these issues have been on review way before 2021. I'm not sure whether there is a cutoff point to such type of ongoing reviews, because I thought the consolidation of the guidelines in 2021 should have been a cutoff point to say either we end, there is no adequate evidence, or else we continue reviewing, because we expected that to appear in that consolidated guidelines. Unfortunately, the guidelines out. Unfortunately, some issues are still ongoing. So I'm not quite sure whether we have any cutoff point for how long these will be under review. On PMC, it's a good development. I'm not quite sure on this PMC whether the first line is recommended for PMC, the first line treatment, or we need to consider using a different drug. Then finally, on IPTP in schools, I know you have said there are no guidelines, but although you recommend that, yeah, where possible, we can implement that. So if a country wishes to implement the IPTP in schools, should it be on a pilot basis in the absence of the guidelines, or we could still proceed with our country policies and still implement it fully fledged? Thank you.
Okay, why don't we take a couple more questions, and there. Do we have the microphones?
My English is not good, but I will try to tell about something. I would like to try to I would like to to bring an experience for my country about that recommendation. The last week we was preparing the BMC for the next year. We are very happy because that recommendation will be in the is in the new guideline. In my country, the last year we did the MDA in the contest with the emergence in the Cabo Delgado, because the Cabo Delgado is a province, the north of my country, was affected the terrorism, and the population moved for another district, and this district we did MDA, one for 3 rounds, and we in the another province we did SMC and contest the seasonal malaria. Thank you.
Thank you. And then, yeah.
Thanks, Peter, for the presentation. My comment is related to the first speaker, and specifically for the IPT in school children. When you mentioned that guideline development is ongoing, is there a need for additional research within the countries to support that process, or is the data available and it's just a process of putting together guidelines?
Okay. Peter, do you want to take those?
Okay, yeah, thank you. I would just respond to this. Yeah, so the first question you raised, yes, the update of the treatment in the first trimester of pregnancy, and indeed, artesunate pynaridine, started in 2017. So you're right. We've been saying we are updating. But for reasons which has nothing to do with data, which has nothing to do with evidence, which is an internal WHO thing, it was stopped and truncated. So that review was restarted again just last year. So we have passed that stage now of all the meetings and all, and it's now in the process of internal clearance within WHO. The guidelines, the way it is now, WHO, malaria WHO guidelines, is a living document. And so it's no longer editions. Previously, with the treatment guideline, we had edition, first edition, second edition, third edition, fourth edition. But now, you will be getting a lot of updates on specific aspects as they become ready. Yeah. So, but I know what you're asking. The first trimester of pregnancy, we started it in 2017, but was truncated in 2019 for internal WHO reasons, not to do with the science, not to do with the data not being available. We restarted it again last year, and we're at an advanced stage now. And so when I say it's ongoing. The question for all the chemoprevention recommendations is clearly stated: you should not use the same drug used for treatment. So you cannot deploy and use the same drug. You can't use your first and second line treatment. The drugs are used for first and second line to do any of the chemoprevention, even MDA inclusive, but that's also part of the chemoprevention. So again, that narrows the availability of what you can use and how and where you can use. But that's the reality. We want to protect drugs we are using for treatment in that particular setting. So if you're using drug A and B in your country, you can't use any of those for any of the chemopreventive strategies. Yep. just to follow on what you said, yeah, a lot is going on in Mozambique. Actually, it's one of those countries where the IPTI plus studies are ongoing, which would help to inform. Let me just make a clarity to the terminologies I'm using. There is the guideline recommendation. Okay? And so when I say ongoing, it is for those three things: first trimester and pregnancy treatment, pronidine artesunate, and the primaquine dosage. Then I subsequently refer to implementation manual or guidance document, which is a follow-up to the recommendation. We have implementation manuals for SMC, for IPTI. We don't have any for school children or post-malaria, post-discharge chemical prevention. So when you ask the question, countries that want to do it, do we need more data? Of course, we don't have. The only information we have available are the studies that were conducted to say this works. How do you deploy it? What do you deploy? When do you deploy it? So we need information on those operational things. Otherwise, when you say as a country, do we pilot or do we implement? What are you implementing? So the only thing you can actually do is to pilot and try what might work, might not work. And please, let's note that none of these interventions are meant to replace. Everywhere they have been done, SMC, IPTI, post-discharge, it has been on top of coverage with case management and vector control. So it's not a situation of, I want to reduce vector control here and put, that's not how it works. And that's the evidence that we have. It is on an addiction, addictive to having things in place already. So yes, we're going to require a lot of pilots. We're going to require a lot of implementation studies, deployment studies to know and understand more about these, which we guide in taking it forward with countries. And we encourage countries and research institutions to key into this, because the more evidence we have, the earlier and quicker we can move it forward. I hope I've addressed the questions. Yes.
We will have more time for more questions after the next presentation. Dr. Karine was pulled away to a meeting, so hopefully Dr. Dadi Waesa from the RBM Partnership to End Malaria should be giving a presentation virtually. Hopefully someone has magically made him appear. Dr. Dadi, are you on the?
I hear, they just told me here that Dr. Dadi cannot join, so I think I have to put on my hat as co-chair of the CRO-SPC.
Okay.
So you're not saying WHO anymore.
My deepest apologies to all the members to have to hear Peter again. But no, we're very happy to have Peter wear his multiple hats today. So Peter, if you'd like to give the update.
Thank you very much. And sorry if you are bored of hearing my voice, you can go for coffee or you can sleep. But I'll just run through these slides. Update from the Rollback Malaria Partnership to End Malaria. Okay, so this is you have the introduction, the work plan, the activities, updates, and opportunities to engage with the working groups and priorities for Q3 2022 onward. So the strategic framework 2021 to 2025, the mission remains to convene and coordinate an inclusive multi-sectoral response to control, eliminate, and ultimately eradicate malaria. There are 3 strategic objectives. Strategic objective 1, to optimize the quality and effectiveness of country and regional programming. Strategic objective 2 is to maximize levels of financing, and strategic objective 3 is to facilitate development and scale-up of new products and techniques. Of course, supporting all of these, you have data sharing and use, effective partnership, focused secretariat, and targeted advocacy and communication. The working groups within the RBM partnership, you have the RBM Partnership Board, where you have the board chair and vice chair. Then the partner committee coordination group. You have the RBM partnership committees, or partner committees, there are 3 of them. And each partner committee has the co-chairs, they report to the CEO. And then you have the working groups, the RBM working group, of which the case management working group is one of such. There's the RBM Partner Committee Steering Committee, and the RBM Partner Committee work streams. Then the RBM Partner Committee Steering Committee have members or the lead chairs from the RBM working groups as part of the steering committee. So in essence, that's the flow. So you have the RBM partnership, the general membership, then you have the partner committees that have steering committees and work streams within the partner committees. And you have the working group, and the working group are integrated in this system because they are part of the steering committee of the partner committees. I hope I've been able to explain that structure. It's simple. It says it's confusing. I will take the confusion as part of question and answers. So I've talked a short while ago about the strategic objective, and the first one to optimize the quality and effectiveness of country and regional programming. Provide TA to countries and regional entities in the following areas: technical strategies and implementation plans, coordinate support for development and validation of technically sound, implementable, country-led malaria control and elimination strategies, and sustained financial plans. So examples of the products there include supporting countries to come up with malaria program reviews, updating national malaria strategic plans, and indeed regional strategies and plans. Resolve implementation bottlenecks, to provide early coordination for warning signs that identifies bottlenecks, both proactively and reactively, and implement a rapid response mechanism to support countries to overcome these implementation bottlenecks. Examples of support that were provided included during COVID, coming up with a COVID-19 mitigation plan, planning and supporting implementation of campaigns including LLIN distribution, SMC, and indoor spraying. The HBHI, high burden to high impact, I spoke about earlier on. Emergency and upsurges, Zero Malaria Starts With Me, data sharing for joint problem solving. And third is resource mobilization. Coordinate and provide technical assistance and implementation support for comprehensive financial gap analysis, development of funding proposals and investment requests, fostering country coalition and coordination engagement with donors at all levels to address bottlenecks and gaps, including cross-border and cross-country collaborations. Already, like we know, the NFM4 is coming next year, so we're already working with programs to update their strategic plans, to update their gap analysis in preparation for January next year, when we enter the whole big race to submit proposals to the Global Fund. And I should say this now at this point, that we encourage countries to, as quickly as possible, update their national strategic plans, source for TA from RBM and from partners to update those plans this year. What you don't want to do is to combine updating your strategic plan and developing your global fund proposal at the same time. It happened the last time, and it's a heavy lift. And there are very few, or the number of consultants to provide support are limited. And so the earlier you put in a TA request and you get some of the preparatory work done before the proposal development, the better and the easier it will be for everyone. So in terms of strategic objective 1, 63% of the targeted number of technical assistance have been provided to countries. 11 technical assistance provided to regional alliances. Technical assistance provided has focused on addressing the COVID-19 associated bottlenecks, national malaria strategic plan development, malaria program reviews, and global fund application. And a joint evaluation of the HBHI approach is currently ongoing. This just shows us what was achieved in terms of the TA support and requests from countries, what was provided 2021, 2022. In terms of LLIN campaigns, 42 requests that were met. For program implementation support, 42 requests. Strategic plan development and reviews, 20 requests. CROG, community rights and gender, that's one area that we're trying to strengthen within countries and in the malaria world. And that's the matchbox, providing technical support to countries to develop the CROG aspects around malaria programming. Support has been provided to 11 countries. Global fund application and grant making, Zero Malaria starts with me, advocacy, resource mobilization. So these are various areas where support has been provided. The impact of the TAs have led to aligning malaria planning with a broader health development agenda and to support mobilization of resources, both at international, regional, and country level. Opportunities to incorporate a mix of new tools and best practices, including strategies to ensure access to everyone. Enable countries to design policies, set new targets, and improve their coordination system, including incorporation of community rights and gender programming. Mainstreaming malaria in the agenda of regional economic communities, including heads of state, ministers, and technical level. And support provided to mitigate against the impact of COVID-19. Strategic objective 2, maximizing level of financing. Support have been provided to amplify the global fund investment case. Malaria-specific case studies, thematic narratives, and advocacy arguments demonstrating impact of global fund investment have been developed for use by RBM partners. Leveraging key moments to increase support for the global fund, especially as this is the replenishment year. So opportunities like World Malaria Day, high-level events, and partner messaging. The CHOGM conference that just ended last week. All these were opportunities to our key moments to increase support for the replenishment and indeed for global funding for malaria and other diseases. Elevating malaria and the voice of the CSOs throughout campaigns, Francophonia engagement, support countries to fill financial gaps. So TA provided to countries and regional entities in terms of financial and programmatic gap analysis that helps them both for resource mobilization externally and within the country. Bridging the malaria community and the 3 disease communities through coordination with the Global Fund and the Global Fund Friend Network, compiling, publishing, and escalating to donors the country's programmatic and financial gaps through the Global Malaria Dashboard. We have the CROSPC bi-weekly calls that involve all major malaria partners, and the data initiative quarterly calls. Strategic Objective 3 facilitates the deployment and scale-up of new products, techniques, or implementation strategies. The subnational tailoring has contributed to this scale-up of new tools, determining how to combine tools or which tools to combine depending on the specific local malaria transmission pattern. Approval of the GF catalytic investments, which includes new tools, and working with Gavi and other partners to support the malaria vaccine targeting. Strategic enablers, which includes data sharing and use, new data, new and improved dashboards, and improved user experience. So that's the flow and the cascade. So whilst we're trying to enhance and support that data in real time as much as possible is captured on all levels, dashboards are being made to make the interpretation and use of this data more friendly and improve the use of the user experience of actually translating this data into programmatic gains used for programming and not just capturing data. When Rwanda, when they were presenting, they were talking about digitalization. We're talking about digitalization. Yes, we're in the age of digitalization, but it shouldn't just be digitalization for digitalization's sake. It should be digitalization to help us enhance, one, rapidity of getting the data as robust and comprehensive as possible. And also we work on rapidity on responding to the data. Otherwise, digitalization would not make any difference if we cannot respond to that data. And it just helps us to ensure that we get it on time, we're able to access it, but we should also work to improve the user experience and response to the data. Strategic enabler 2, effective partnership. I talked about the partner committee meetings, monthly meetings are held. We have 2 meetings every month. Cross-partner committee meetings held on 15th of March 2022 to plan for the year. I've been appointment of an interim for 1 year advocacy and resource mobilization partner working committee. And, okay, move on. Strategic enabler 3, targeted advocacy and communication. I've spoken to this earlier on, supporting resource mobilization activities that took place in last week here at the Chogom 2022 Kigali Summit, supporting efforts towards the 7th replenishment investment case for the Global Fund, and the establishment of global end malaria councils. In most countries, they are moving in that direction, actually moving malaria high on the political agenda and working with countries to see how you move not just to the political agenda, but translating those political currencies into real currencies at country level. So when you involve high-level people in government, in society, like I always say, zero malaria starts with me, means that we should all internalize that everybody has a role to play. The religious leaders have a role to play, the community workers have a role to play, community leaders have a role to play, the private sector has a role to play. And when we can harness all of this, we should translate all of these political currencies into financial currencies for what we need. Rallying the community, using the various avenues, raising the urgency of the malaria problem, and keeping the partnership informed through newsletters, op-eds, website, and social media. Strategic Objective 4, the focus secretariat, because you need a secretariat that is empowered and focused to help guide the work of the overall partnership to ensure effective delivery on the strategic plan. Opportunities to further engage with working groups. Co-chairs are the members of the partner committee steering, or are partner steering committee members. This will give an opportunity to work with each other co-chairs. So when you have the different working groups, the co-chairs are members of the steering committee. That's an opportunity to work together, to know what is happening, and to cross-fertilize. And also at the CRO-SPC annual meetings with National Malaria Control Programs, which is currently ongoing. We had the first face-to-face meeting 3 weeks ago in Nairobi. For the Southern African countries, it's next week in Harare. And then there is, for the West African countries, in Senegal later in July. And for the Central Africa countries in Brazzaville in the second week of August. And so these face-to-face meetings gives opportunities not just for program managers, but for partners, both country and external partners, to come together and to share experiences, address bottlenecks, and to plan going forward. Key moments for advocacy and communication engagements. These are just different landmarks and different areas where communication and advocacy has been used or has been tagged to major events that were ongoing as a way of raising the profile of malaria or keeping the profile of malaria high up there on the political agenda, both globally, regionally, and nationally. We need to do that. I told someone not long ago, how can we shock the world with malaria? Because the world was shocked with COVID, and the response was instant. When it comes to malaria, we sort of used to it. Oh, malaria, yeah. The man didn't come to work yesterday. He had malaria. Oh, malaria. It's like you don't complain about that. So we need to get our acts together of how to remind the world that as we speak here, X number of children are dying from malaria. X number of pregnant women are dying from malaria. So it is not something we can live with. And we need to continue to put that high up on the agenda. And it's not just an issue of people dying. It also has their economic consequences of national growth, because that's the language the finance ministers understand. Money and economic growth, not debt. Priorities for the next month going forward. I've spoken about the CRO-SPC sub-regional malaria program and partner meetings. There's the UN General Assembly coming up in September, and then the Global Fund replenishment, which will be launched on the side as part of, during the UN General Assembly. Support to countries in the Global Fund request in 2023, already spoken to that. Already part of these sub-regional meetings is preparing countries towards that when by December the Global Fund begins to release the allocations. We are well prepared as a malaria community to put together robust proposals with the right gap analysis. As always, RBM will provide consultant support, both international and national consultant support. We'll provide some resources for in-country activities, preparation of the Global Fund. We would also, as always, organize the mock TROPs to help in bringing together your proposals to a stage where we would expect more than a 90% success at the first submission. And we plan to have an orientation meeting in December once the Global Fund have all their tools ready to prepare the countries for the NFM4. And in addition to this, you have the remote support provided to all countries with their proposal development. So I think that's the end of the presentation. Thank you very much.
Thank you, Peter. If you're welcome to come sit here, and we can take questions from there, so you can rest your feet after, what was it, 7 presentations in a row? Actually, while Peter's sitting down, a few housekeeping issues. One, just to remind people, we are recording this, it's streaming live on YouTube and on Zoom. So when you ask questions, please use a mic so that the people viewing can view it. For people who are viewing this on a live stream, unfortunately, given the size of the audience, we're not going to be able to take questions from the virtual participants, but we do appreciate your participating. We have a large group and we have a lot of people with questions. So for tomorrow, for the field trip, we're there. Adam, could you raise your hand? And Lena? Oh. They're gonna circulate a sign-up sheet. So if you want to go on the field trip, please put your name. And also, we're asking if you would prefer, would prefer to speak French, speak English, or you're comfortable with both languages. So we can make sure that you're in a group where you can speak your appropriate languages. And apologies to our Lusophone colleagues. Unfortunately, we don't have Portuguese translation. We can start circulating that sheet around, and please sign up before you go to lunch. And lastly, Lena, do you want to raise your hand? For those who were sponsored by Swiss TPH, please see Lena about your allowances. And anything else? Was that, yep, Adam?
Yeah, just one more. We also have, we were given like lunch vouchers for lunch, so Lena and I will hand those out. They won't give you the lunch without the voucher, so don't run off without it, please.
And so, yeah, and we won't give you the voucher until you sign up for the field trip. So, so please do that before we have a good amount of time. We have more than a half an hour for questions and answers on both presentations. Fortunately, we only have one person to answer all those questions. So I'm gonna show of hands of anybody who has questions for the presenter, for Peter. Prudence?
Okay. Hello. Thank you, Peter, for both presentations. I was wondering, in your guidelines, have you got any information for countries? Is the introduction of the RTSS vaccine and also upcoming vaccines, and how they can coordinate with Gavi and other funders of vaccines, and how that will affect the chemoprevention activities?
All right, other questions? Busiku?
Thank you very much, Larry, and thank you very much, Peter, for those two presentations. Mine is going to focus on your WHO hat, the guidelines. In Zambia, we've had this conversation around IPTP at community level. But when we interact with our colleagues who are in the reproductive health space, they're always concerned about, impacting reproductive health services for our pregnant women, including institutional deliveries and other services that go with pregnancy. I just wanted to solicit your thoughts in the discussions that you've had, if this issue has come up, and what are the preliminary discussions in terms of how this can be addressed as these guidelines are being developed. Thank you.
Okay. Others? Oh, wait, we have one back there.
Thank you. Yeah. So thank you, Dr. Peter, for those presentations. Mine would be, just like you said, it's very heartwarming that you said the guidelines are still a live document, so it means a lot is still, going to happen around interventions. So I just wanted to say, since we're coming up with a lot more interventions, I hope we're going to be seeing kind of a little bit more guidance on how the interface or interlap of these interventions can be happening. I'll give you an example, when you talk about SMC, and it's, given to under fives. Some of these under fives can pass for school children, like in nursery school, and so we're doing IPTI in school children. So, and we know that, we don't know how the guideline is going to come out for school children, but we know that sometimes schools can start in some countries from August, and SMC is still happening to these children. So, are there going to be some instances where there will be guidance on how to manipulate or maneuver these things so that you don't continue to, these children don't get overdosed with medications or medicines? I don't know if I'm clear enough. Also, another example for us in Nigeria is a situation where we have, like in a state, 2 interventions running based on what we have done in terms of stratification that WHO also guided. We have, like in one state, where SMC and IPTI, it's supposed to be happening, but in different LGAs. So how are we going to, get a control? Can WHO speak to that? Because we know that we may be, conscious or aware of the implications of that, but the caregivers who are desirous of their children getting intervention may as well be presenting their children for IPTPI and SMC, since they are happening in the same state but different LGAs. So these are issues that would also like WHO to kind of give guidance on. And then finally, on the second presentation, I just wanted to say, when you say update a strategic plan, for us in Nigeria, like our strategic plan is up to 2025. So how do we go about it? We know that from what is happening now, the updates that are coming up, we're seeing some little lags or something, or gaps in terms of implementation. So I'd like to, have you throw more light on that. Thank you.
One more, and then we'll let Peter respond.
Thank you. My question is again on the first presentation. I just want to be cleared on this drug that you mentioned that was under review, Pyronardine artesunate. I hope I got you correct to say it was under review. I also am aware that it's now WHO pre-qualified, and WHO issued out an information note in 2019 indicating that countries can procure and include the drug in the treatment guidelines. But you've mentioned that it's still under review. I just wanted to be cleared on that. Thank you.
Okay, well, we'll take more questions, but let Peter take the one so far.
Okay, thank you. Before I lose track of the questions. Vaccine, that was the first one. In the guidelines, there is a section on vaccine, which is the recommendation. Of course, it doesn't address implementation, which is not the remit of the guidelines. Because there's a group that is working on how best to deploy the vaccine, who gets where, especially because of the limited, because the biggest challenge we have with the vaccine right now is the demand outstrips the supply, and that's going to be for a while. So countries are not going to get the doses they require. And so there is a mapping ongoing and a group working on that, a task force working on that, on how to support countries and in those meetings, like all the country meetings that we have organized, like the Nairobi meeting, they actually spoke to countries, they addressed those particular issues. But the guideline itself just speaks to the recommendation that the vaccine can be used and in what circumstances. So that's ongoing in parallel to the recommendation itself. Reproductive health services and the community deployment of IPTP. Yes, they have been involved in all of these, involving the reproductive health programs. And I think they are right. What we do not want to, and that was one of the goals and the objectives of the Tip-Top project. One is delivering IPTP through community services. Would it increase the uptake of IPTP? And two, will it have any negative effect on ANC utilization? Those were the two things that were looked into. So I think the answer to that question is, just like I indicated when we were talking about ICCM, community health workers, the community delivery platform should be part and parcel of our health system. It's a continuum of care. We can actually set it up in such a way that the fact that you have a community delivery platform would actually enhance women from the community utilizing ANC services because they are seen as part of the process. So it shouldn't be seen as a rescue mechanism for a failing system. It wouldn't work, but rather as part of enhancing the system to increase reach. And that's how this has been developed. And that's why it's so important that the implementation guidance document clearly reflects all of this. So even in the recommendation, the reproductive health colleagues and all were involved in providing comments to ensure that. But even now, with their own recommendation, where they talk about 8 contacts, those contacts are not necessarily ANC contacts. So that's is how do we all work together? So in answer to your question, and at country level, I think you should continue to work with the reproductive health program that look in school age and all that. That's a policy issue, which is country specific and depending on what you want to integrate. That can't be addressed by WHO guidelines. The guidelines will tell you what works, where, when, and how. The mixing of this is policy development at country, which is country specific. Of course, yes, WHO will continue to work with countries along with the partners to help to integrate these things at country level and to deploy this. And when we talk about stratification, subnational tailoring, it is all part of the planning process to make that work. And please, we cannot deploy malaria strategies in a vacuum. It's part of a system. And so, like the question you asked, if in a state you have different local government areas doing, how do you prevent the... My first question is, what is the lowest unit of planning in your country? If you do not take that into consideration when you're doing subnational tailoring, you just come up with a map colored, combine this. You can't deploy it because malaria does not have a separate deployment system from the national deployment system. So if your lowest unit of planning is at district level, it may be very difficult for you to stratify things below the district. It might work, but it depends. So why am I saying this? I'm saying that there's not one size fits all. And at the end of the day, it is translating guidelines into policies as it fits within the country. And country data, country context, acceptability, and all of that comes into play. And WHO will continue to provide support for that to happen. And that's where some of those implementation guides become important, because it looks into some of those specificities that would guide countries in what to do. NSP updates and cycle, please do not change your NSP cycle to fit Global Fund or any funder. Your NSP cycles and your country planning program is the starting point, and every other thing derives from that. So you should not just update your national strategic plan because you want to do NFM4. No. It should remain within your planning cycle. There are situations where in your planning cycle, it does not necessarily align with the Global Fund cycle. There are ways that is dealt with, and that has happened in the past, where countries have had to extend by 1 year to cover the Global Fund cycle. But please remain within your program review and your planning cycle in the country. And support will be provided to help to align this with the different requests from countries. There was the issue of information notes, attested paranarydine. Again, it goes back to the point I made with the information note. Information is an information note. It's not guideline. Guideline has a process. So as of the time the information note came out on attested paranarydine, it was not in the treatment guideline. So as of today, attested paranarydine is still not in the treatment guideline because it's in the process. But that was an information note, which is not based on anything but an information. And that's, when you look at WHO cycles and all, and what have you, information note is not, I can produce an information note for my unit. That's not something pre-qualified by WHO, and it's not in the guideline. And I'll give you a typical example. You're referring to, since we're speaking about attested paranarydine, part of the WHO pre-qualification process is what is called listing. If a drug has passed through some stringent regulatory authorities, getting it onto the WHO pre-qualification lists process, if it has not gone through that. And so, if there was, so for this particular product, yes, it's gone through stringent regulatory authorities, registered and that, and they made a submission of pre-qualification, and it was pre-qualified before coming into the, which we are trying to avoid in both ways. And just to note that, but once guidelines have told you what to use, when and how, then you're looking for a product of good quality and standard. That's pre-qualification. And there are several pre-qualification methods. WHO is just one. Others have theirs. Even countries, sometimes you still go to do your own qualification of going to the manufacturing site and all of that. So let's put them in perspective. But we are working to ensure that they are harmonized as much as possible so that there's no delay between one and the other. Thank you.
Thank you, Peter. So we have time for some more questions. Okay. Oh, she's got the microphone, and then you can pass it to her.
Thanks, Peter. My question is on some aspects of the guidelines, especially as relates to chemo prevention. For treatment, it's clear what to use.
Questions? See any? No. I would also mention on Thursday, we will get an update from the MIP working group, and they can also address some of these issues around IPTP. I'm looking at you, Kate. Go ahead.
Thank you. I have a question about SMC, and we have the criteria to begin SMC, but we do not have information about after how many years we need to stop SMC, or we can continue, or for many years we don't have information. I want to have some information about this. Thank you.
Elizabeth is laughing at me. Okay. For the drugs to use for chemo prevention, I think there is the preferred product characteristics. And happy Stefan is here. Maybe they might speak to that at a certain point. Yes, I get the point you're making. As of today, we have very limited options for the chemopreventive therapies that are recommended. SP has been used for IPTP, IPTI. Even for SMC, it is amiodarquine plus SP. And there have been some studies where they have used some of the ACTs, but that is a complete mismatch because we say that from a pharmacological perspective, you want the two drugs to have as close half-life as possible. So if I'm actually using DHA piperaquine for chemo prevention, it's actually piperaquine I'm given because your dihydroartemisinin is gone in 8 hours. And that kind of a thing. So that's a challenge with using it. So we have very few options, honestly. That's the truth. Even for malaria, the whole portfolio of medicines for malaria is very limited. And, but there is a preferred product characteristics that's been developed, and some exist already. WHO is also working on one with partners on what the ideal would be and what options are out there for chemo prevention, drugs to use for chemo prevention. And I think even now, the role of chemo prevention in malaria control and elimination is an area that has been further developed and looked into. For a very long time, it was just chemoprophylaxis, using suboptimal doses for travelers, people moving from non-endemic to endemic areas for a period of time. But the whole concept of chemoprevention I think it's something that still needs further discussion from a malaria perspective, not just from a drug perspective, as to the role and what role it looks like a quick win situation. Yeah, if you give anti-malaria medicines, you're going to reduce burden. But what does that mean in the context of malaria control and elimination? Where does that take me? If I reduce burden in Nigeria in a state for 3 months, what does that mean? Having a discussion yesterday with someone, and we were talking about, yes, we say malaria, the epidemiology is heterogeneous, it's not homogeneous. That's true. But even within the heterogeneity of malaria, we know that it is not clear-cut, and it's a sliding scale. And there need to be some drastic reduction before it affects intervention. So areas where you're having a certain level of transmission, 60%, what you need to do there would remain exactly almost the same thing you need to do in areas where it is 10%. It might need to reduce way down before you change. So really maximizing the interventions that we have. The folic acid, iron, and SP, IPTP, I think the question here is actually the folic acid, because there's a recommendation not to use the high dose 5 milligram folic acid, which in the first instance the woman doesn't need. However, it's just that that's the most available one. What she actually needs is 400 micrograms of folic acid, which will have very little effect on your XP. But you don't want to use the 5 milligram folic acid. And I'm sure the reproductive health, the MI people would also tell us that they are looking for ways to bring in the right dose of folic acid that is required in pregnancy. and that will reduce the issues of, do I stop for 2 weeks before IPTP? Do I wait? Which becomes confusing when you're trying to implement. RAS at community level, I spoke to that during my presentation. Rectal artesunate as a pre-referral treatment. It's a recommendation of WHO. Studies, control studies have shown that it has a life-saving effect. However, for us to maximize this effect, it has to be, the package has to be complete. Pre-referral treatment, that's what it is, pre-referral. And then we want to ensure as much as possible that referral happens and that where the patient is going to, they get more treatment. It would not be very effective if they get the pre-referral, they get referred, they get to the center, there are no drugs. Or pre-referral treatment, get referred, they don't go to the referral. So it's part of a package. So the problem is not with the rectal artesunate. The problem is strengthening the system to deliver the rectal artesunate for maximum effect. So yes, the recommendation stands, and it's a recommendation from WHO. And then when do you stop SMC? I don't have an answer for you. However, I would answer it the other way around. And I think that's where the implementation guide is helpful. When SMC was introduced, there were clear criteria. Seasonality of transmission, the level of transmission, as to the number of incidents per what have you, they are all there, which also fed into the cost effectiveness of the intervention. So you can use those in a reverse manner to see at what stage is this no longer cost effective? At what stage can I get better public health value from spending this money on something else than on SMC? But see, those are policy country level discussions, which guidelines would not provide for you. Thank you.
Yes, and I'm sure in Senegal the question is, when do you switch to an elimination footing, right? And so,
when do you switch? Because now, okay, now I guess the question you actually asking is, when do we switch SMC from being an intervention to reduce malaria burden, disease and death, to transmission reduction? But SMC was never developed or recommended for transmission. It was to reduce disease burden. And if we go by the recommendation now, we're actually seeing in children with high levels of mortality and severe disease. And that can, at a policy level, actually exclude older children, because you're not moving to SMC there because they are having severe malaria and dying. Those who have severe malaria and die are the under fives. So all of those are the various things you put into the package to help you make a policy, country-specific decision. Thank you.
okay, other questions? Okay, we'll take two more, those last two. The gentleman in the back, and then Naomi.
So thanks, Lara, and thanks, Peter. So I don't know if I should be asking this question, but I've not heard the mention of chloroquine. And I know there's been a lot of resistance. We've documented that in many studies, but we've also documented the return of the wild type. And is there any discussion anywhere, WHO or others, on the return of chloroquine back to the table? Just a kind of controversial question, but I would like to hear your thoughts. Thank you.
Okay, just a quick one. With not using first and second line antimalarials for chemo prevention, does that apply to post-discharge malaria chemo prevention? Okay.
And I assume your question about chloroquine is specifically about falciparum, because we do still use it for Vivax.
Thank you, Larry. You just took the easy answer from me. And then I was going to say, when you say return of chloroquine to the table, which table? No, I think the question you're asking is the wild type. Is there the possibility of chloroquine regaining efficacy after resistance? Are we discussing that now? The answer is no. And I think there have been instances undocumented where in Southeast Asia, in some parts, at least I can remember that, where there seemed to be some recovery of chloroquine, and once you subject it again, almost immediately you lose it. And I think the resistance development mechanism is very different from something like mefloquine, where when you stop the use, there is a reversal to do with the wild type and all of that. But is that being discussed? No. But chloroquine is still being used for Vivax. And that's, but like I said, in the bigger pipeline of everything, it's, I guess there's room for that discussion as to which other options, which combinations, or how. And in a way, Preparaquine is actually two chloroquines put together. I didn't say that. So for post-discharge malaria chemo prevention, if we can use drugs for first and second line medicines, that's why I said we are still going to look at more data and information to properly define what we mean by post-discharge malaria chemo prevention. Because the way it is, we say in patients with severe anemia. It will be very different if we are talking about severe malaria anemia, because then I would already have treated with anti-malarials as part of that. So at what point do I give the second drug? So there are lots of practical things that need to, and like I said, we need to work with countries that are willing to pilot this to learn more. And we are also speaking with some of the research colleagues and communities to come up, maybe when they have a consortium, to work together, just like what is being done for perennial malaria IPTI plus, to actually ask these questions and go out there and develop operational research questions to answer this as quickly as possible in an organized way. So I can't answer your question based on the information that we have right now.
Okay, sounds like there's some research need to be done.
Yes, a lot. Even the guidelines say so.
Yes, answers for you, but I want to thank Peter for providing. That's. And I think he certainly earned his lunch, so maybe we let him go first in line to the buffet. Hopefully everybody has signed up on the sign-up sheet. And Lena or Adam, logistics for the lunch, or there are vouchers. I assume we're in the dining room. Okay. 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 All right, so see her at 1400 hours, 2 o'clock, 2 p.m.
I've worked with him.
I know.
5 years.
It
hasn't changed. Could you hear? I mean, there was,
Well, I just not concentrate. Yeah.
there was quite some discussion on whether we have the right topics available.
Yes, we definitely do.
On severe malaria.
Well, and for chemo prevention, if you want to avoid using first and second line,
Yeah.
what do you have then? The WSP.
Yeah.
Yeah. Which is always, not great. Underneath, press underneath. It'll say off.
We are privileged to tackle, of course, one of the most important topics in malaria case management, which is severe malaria. And as we heard from the presentation of the guidelines, this is the last step before death. So if we manage severe malaria, we prevent, if we do it well, we prevent mortality. There are lessons that have been learned from studies in severe malaria in the last 3 or so years, and we have the pleasure this afternoon of having those results be presented to us. So for this session, we will have 2 presentations, and then we will have a panel discussion where we will hear sharing their experiences, either with these pilots or with programmatic implementation of various aspects of severe malaria. To start with, we are going to hear findings from the Caramel study. And I'm having a senior moment right now. I knew what caramel was. Community access of rectal artesunate for severe malaria study. So caramel study took place together with TIP-TOP, which was the IPTP at community level study. They took place in similar countries at almost the same time. And so to share the findings from this study, we have Phyllis Award from Makerere University to share with us. Welcome, Phyllis. So you'll just press down. Thank you very much.
Okay, good afternoon. Thank you to the chair, and it is my pleasure to share with you results of the Caramel Access. Indeed, that is Caramel in full, and I'm focusing on this title, Understanding and Improving the Case Management of Children with Severe Malaria in DR Congo, Nigeria, and Uganda, where we did the study. I'm making the presentation on behalf of the entire Caramel Consortium, which was research partners in DR Congo at Kinshasa School of Public Health, in Nigeria, Akena Associates, in Uganda, Makerere University. The implementing partners, which were the National Malaria Control Programs and UNICEF and Clinton Health Access Initiative, and our enabling partners, the funders, UNITAID. We had WHO and MMV taking some roles. Okay, so we have seen from all the morning presentations that severe malaria is a medical emergency, and the recommendation is, as was presented by Dr. Peter earlier, parenteral artesunate and a full course of artemisinin-based combination therapy. And the recommendation for a pre-referral treatment with pre-referral rectal artesunate was also well discussed and described, where there's no IM injectable artesunate, treat with a single dose of rectal artesunate and refer immediately to an appropriate facility, children less than 6 years. Okay. So the evidence of pre-referral rectal artesunate that really built on to the Caramel study was with Gomez and partners, who showed that pre-referral rectal artesunate reduces case fatality rate in children less than 6 by between 26 to 51%, with very high levels of referral completion, and a more recent study from Zambia showing that pre-referral rectal artesunate in combination with a strengthened referral and post-referral treatment reduces by over 90% severe malaria case fatality rate. That was in one district in Zambia that provided emergency transport systems, no drug stockouts and all. So the evidence for the WHO guidelines really is optimal conditions, especially with the Gomez 2009 study. However, Caramel was interested in understanding optimal ways of rolling out rectal artesunate at scale, where there was no major supportive interventions. And so we were doing an effectiveness study of an efficacious product, rectal artesunate. And our goal was to contribute to reducing malaria mortality in children by improving community management of suspected severe malaria, with a few research questions to understand the minimal health system requirements for rectal artesunate to be an effective part of the continuum of care for severe malaria, to understand any unintended consequences of implementing rectal artesunate at scale. And really the main question was, can the introduction of pre-referral rectal artesunate reduce severe malaria case fatality under routine operational circumstances? We also looked into the cost and cost effectiveness. As I said, we worked in those 3 countries, DR Congo, Nigeria, and Uganda, in those districts shown with a population of about 2.5 million and about 500,000 children under 5. And quickly, the operational activities. This was an operational research study. And we did annual healthcare provider surveys and annual household surveys. But the main data collection tool was a continuous patient surveillance system, a continuous patient follow-up where we followed up children from when they went to their first primary healthcare provider and up to 28 days afterwards with 3 time points. And I will elaborate further. But we collected data for 10 months in these districts before the introduction of rectal artesunate and for 15 months after rectal artesunate introduction. And at the bottom, we were interested in the children that we enrolled were children under 5 who had fever and a danger sign of severe disease and a positive malaria rapid diagnostic test. And then on day 28, we call that day 0, and then on day 28, we visited them wherever they were to understand their health status, are they alive, dead, still sick, etc. But also we did hemoglobin testing, malaria rapid diagnostic testing, and just try to understand the entire treatment cycle. And for a subsample of them where we, because we stationed staff in different health facilities, but not in all the health facilities in the study area, but a subsample were monitored directly in the health facilities as well. And I will move to the next slide, which is just showing the continuum of care from when a caregiver recognizes severe illness and really what they need to go to end up with a positive outcome at the end. And for us, the key areas of analysis were really understanding rectal artesunate implementation and its coverage, and then of course the outcome of the child at the end, understanding the severity of illness, and then the treatment-seeking pathways undertaken, and the treatment at the community level and treatment at referral health facilities. So those were the key, key analysis points. This is just showing you where we collected data from, and in the different countries before and after rectal artesunate introduction. So we collected data from community health workers, children seeing community health workers, children going directly to health centers, and children going directly to referral health facilities. And as you can see in Uganda, there was more, the data set includes more children visiting community health workers, and in DRC, more children visiting primary health centers. That's really how the integrated community case management programs are run, with a total of nearly 14,000 children that were included. Okay, quickly, just some photos of the field activities with the training photo at the top there, some supervision visits, what the terrain looks like out in the field, as you all know, and just a picture of what our health facilities look like in these areas. So on to the results. This is showing us the recruitment, and you can see the bars at the back are really how we recruited children into the follow-up, the patient surveillance system. So really continuously throughout almost 3 years of data collection. And in all the 3 countries, DR Congo up, Nigeria, Uganda. And the line is showing the availability of rectal artesunate in the countries with the as soon as it was introduced in the study area, high uptake in DRC, an increasing uptake in Uganda, and challenges with availability in Nigeria. But really all getting to high coverage levels eventually. So the key results, I'll present each per slide. And this is looking at referral rates from a primary healthcare provider, so from your community health worker or the primary health center. And we found that in all countries, referral completion to the referral health facility after receiving rectal artesunate was lower among the rectal artesunate users compared to the non-users. And particularly in DRC and Nigeria, the results are statistically significant. And indeed, if rectal artesunate is contributing to reduced referral rates, in addition to all the other contributing factors, which are family-related factors and all, this certainly compromises treatment and hence survival of children. And so management now at the referral health facility. So from that subset of children at the referral health facility, we actually found that injectable anti-malarials, particularly injectable artesunate, was very high in all the countries, over 90%. And in DR Congo, a full course of artemisinin combination therapy was given to the children to a level of about 80%. However, in Uganda and Nigeria, providers mostly gave a prescription instead of the actual medicine to the discharge to the child, resulting in moderate levels of ACT treatment of children at health facilities in Uganda and very low levels of about 2% in Nigeria. And consequently, the full course of treatment, which is the parenteral artesunate and an ACT, was fairly frequent in DRC, moderate in Uganda, and very low in Nigeria. So this is really the picture showing us that, certainly incomplete doses contribute to incomplete cure and monotherapy as well, implying a higher risk of resistance development. So the next result is on case fatality rates. In total, we experienced 223 deaths in all this, almost 13,000 children. But the case fatality rate at the community level was different in the countries. So the settings are very different, 6.7% in DR Congo, 11% in Nigeria, and very low, less than 1% in Uganda. But as expected, usually death occurred in the days immediately after enrollment, immediately after the onset of illness, really. And the figures on the right are showing us the survival curves, really. But in the middle in Nigeria, we found that mortality was higher in the rectal artesunate group, to a difference of over 10%, and marginally so in DRC on the higher curve, the higher figure. I mean, showing us, we get a result that is opposite from what we expected. We have an efficacious product, but certainly giving rectal artesunate does not directly contribute to survival or death. It's everything else that happens along the way until the child dies. And this is a big eye-opener to all of us. Okay. So on day 28, we went back home or wherever the child was and did a rapid diagnostic test for malaria. And we found 44% of the children in DRC still positive for malaria, 50% still positive for malaria in Nigeria, and 70% in Uganda still positive for malaria. So a lot to discuss around this, but certainly issues around remaining circulating antigen, maybe new infections. And that is also a very important finding for all of us in the room. But also we found that a substantial portion of these children, about 20% in all the countries, were still sick 28 days later after their illness. And all this is showing us that patient management for severe illness is generally inadequate. We have remaining these high levels of positivity 28 days later, children still sick, a bit of all the mortality we've seen. Okay. And I switch a bit, as I'm coming to the end, to a slide on treatment seeking. So I'm trying to highlight the importance of understanding the treatment-seeking pathways. And this is focusing on Uganda, where most of the children saw a community health care worker who referred them to an approved referral health facility, but only 59% followed that recommendation of referral. And we found that many children were brought to a private clinic, even though the community health worker rarely recommended this type of provider. So 30% going to a private provider. And we also found that children brought to a private provider were more likely to receive injectable treatments than from other sources. So this is bringing in the importance of understanding your treatment-seeking patterns, your providers, and what to do about them in an individual setting. So in terms of the observations, I think a key observation is around the management at the referral health facility, where we found that many children did not receive the artemisinin combination therapy after rectal artesunate or after the injectable artesunate, contributing to, resulting in monotherapy for sure. And also the SCTs were often provided as a prescription only, expecting caregivers to purchase the medicines. So I think the implication really is to ensure in some way that we have a full course of ACT dispensed at the referral facility, perhaps with the first dose, which is easy to monitor, taking at the facility. And of course, ensuring the commodities exist, strengthening the supply, monitoring of these supplies and all, and training of our providers. Okay, so the main conclusion of Caramel is that in the countries that we did this work, the efficacious product, rectal artesunate, was introduced where there was weak health systems. It was the intention, and the countries were passively selected because of the health systems, the status of the health systems. But we still, we identified, as we already know, the multiple system deficiencies which contributed to low cure rates and high case fatalities. And I think finally, RAS really should be rectal artesunate should be looked at as part of the continuum of care for severe malaria. And without considering the health system as a whole, reducing case fatality for severe malaria is unlikely to be achieved, because you need to understand everything else that we've tried to show, the treatment-seeking patterns, supply of commodities, management at referral health facilities, etc. So I think I'm coming to the end of my time, but I'd like to thank the entire consortium partners, team, colleagues at Swiss TPH in particular, and our funders and the enabling partners. Thank you very much.
Thank you very much, Phyllis. Don't go too far. And okay. You had spare slides and you had 2 minutes. You could have presented them, but thank you very much for that overview. I would now like to invite Dr. Stephen Dupac from MMV to present us with a report of the Severe Malaria Stakeholders Meeting, where findings from this study were presented and stakeholders had an opportunity to give their inputs. Welcome.
Okay. Thank you. So first, I would like to thank the organizer for inviting me on the behalf of the Severe Malaria Access Group at MMV. And I would like in particular thanks my colleague Hans Riedvel, who organized the meeting together with SHI under the auspices of the RBM Malaria Case Working Group. And also he prepared these slides for me. So I'm really thanks to him. And as you can see, so it will be a debrief on the severe malaria global stakeholder meeting that was organized last February. So what was discussed at this meeting? First, we put the meeting in the context of severe malaria. We spoke of I will show you the objective and the key themes of this meeting. Then I will show you some selected contributions from countries as well as remarks from the key agencies. Then I will have a slide on the update on the WHO pre-qualification guidance on the rectal artesunate storage. Finally, I will show you the key messages that came from this meeting, and I will finish with the acknowledgement. So first, the meeting was based on 4 pillars. First, the rising mortality in malaria that was reported in the 2021 World Malaria Report. Also on the report of the artemisinin resistance in Africa. On the Caramal project, and you have just seen the presentation on the result of this project. And finally, on the guidance of the WHO regarding the use of rectal artesunate as a pre-referral treatment for severe P. falciparum malaria. It was also built on previous meetings that were organized in 2011, 16, and 19. So on day one, we were focused on the latest information and evidence available on rectal artesunate and injectable artesunate plus SCT use, with presentations on the progress update toward adoption of RAS globally, on the RAS implementation experience from the Caramal and beyond, on the latest WHO operational guidance on RAS use deriving from Caramal findings, on the artemisinin resistance update in Africa, and finally, on the update on RAS formulation and temperature stability under field condition. While the second day was focused on the implications for rectal artesunate and injectable artesunate plus ACT use as part of the continuum of care. So here is a slide with the agenda. The first day, it's small, a little bit fuzzy, so I will not go in details. It's just to show you how was the meeting organized. So it was 2 days of meeting and 3 hours each day. That was at the time where we could only organize this type of meeting, and it could not be longer than 3 hours. So the second day, so I will pass quickly because you cannot see so much. Regarding the stages of continuum of care for severely febrile child, so it was presented by Phyllis in the previous presentation, so I will not go in details, but I think what is important is point 4, and it was raised by Peter this morning. We need to be sure that the referral for the treatment is sufficiently equipped to properly treat the patient. So it's an important point that needs to be followed up. And after the last point, which is important, which is point number 6, is the fact that rectal artesunate need to be followed by 1 day at least of injectable artesunate and by treatment with an SCT. That is really the key point here that need to be addressed. Regarding the country experience in implementation of RAS, so as I told you earlier, I will show you a selected contribution from 4 countries. First, Zambia. So for Zambia, the implementation of RAS resulted in a reduction of case fatality rates of 97% and 87% in the pilot and the scale-up districts. The experience shows that strengthening the health system, including ICCM, is a paramount to successful RAS implementation. For Senegal, in villages with difficult access to health services, 2,218 literate community health workers in 35 districts were selected by their community, trained and supervised. by deploying RAS to children with danger sign of severe malaria, along with seasonal malaria prevention, led to a decrease of severe malaria of 66% and a reduction in mortality from 158 to 93 cases between 2015 and 2020. In Uganda, RAS was delivered through the ICCM platform to children below 5 years of age at community level and to children below 6 years of age at health center 2 levels, and where treatment for severe malaria was not available. RAS was included in the ICCM and the IMM guidelines, and information on RAS was included in social and behavior change communication. The use of parish coordinators as part of the supervision structure delivering the RAS to the village health team, avoiding expiries of the suppository. Mortality and clinical audit were done to improve severe malaria management. Regarding Sierra Leone, in 2019, PMI supported the Sierra Leone and MCP to procure its first supply of RAS for national rollout in 2020. Nationwide training, which was a recognition of danger sign, the RAS administration, the effective referral, and the reporting of best practices were conducted, and RAS commodities were supplied to 2,452 providers across 14 districts. A rapid assessment took place in 2020, supported by PMI, in which health outcomes of patients receiving pre-referral interventions were documented, and a review of 134 records of patient journey along the continuum of care was performed. The record reviews showed that approximately 96% of referral form made it to the referral facility, but only 7% made it back to the referring facility. Regarding the remarks from the key agency, so for PMI, emphasis should be on strengthening community health services, and they will work with country programs and other stakeholders to implement RAS in line with the WHO recommendation, and will at the same time work to avoid interruption in services and in the supply chain. For the Global Fund, Caramal results are a call to action and an opportunity to work on health system strengthening. They will continue to work with countries and partners to strengthen community health network and structure to enable the optimal use of RAS and give broader health system support to improve the continuum of care. For WHO also clarified that they will not issue criteria or indicator to monitor when health systems are ready to deploy RAS. Rather, WHO's guidance is that RAS should be deployed responsibly, and that as part of the RAS implementation, strengthening referral systems and quality of care at hospital level should continue, ensuring access to correct management of severe malaria. Action to be taken to achieve this will be different for each country and each setting. For UNICEF, it is important to professionalize and motivate community health workers, to increase domestic external financing for community health, to improve the quality of service provision at community level, including strengthening referral and counter-referral mechanisms. Regarding the update of the WHO pre-qualification guidance for storage of artesunate rectal capsule, so utmost care should be taken to avoid excursion above 30 degrees centigrade. It is a key point here. This may not always be possible, at the level of the community health worker when they are located in area where the ambient temperature is usually above 30 degrees centigrade. So we must ensure that the product is distributed to community health workers located in such area only as a short-term stock, generally not for more than 6 months, depending on the remaining shelf life of the given batch. Regarding the concluding messages from this meeting, first, RAS as a life-saving intervention should be made available to all children with severe malaria in accordance with the WHO guidance. Strengthening of referral and post-referral services should be prioritized and supported on a continuum basis. RAS must not be withheld from any child where no alternative is available. And finally, the treatment needs to be completed with 24 hours of injectable artesunate, and as I said previously, with a 3 days of anesthesia. So just to confirm that we had more than 200 people at this meeting, representing 35 malaria endemic countries from 27 global organizations. And I would like to thank PMI, the Global Fund, the WHO, Médecins Sans Frontières, UNICEF, Clinton Organization, and the RBM Partnership for their support and for the work they have done with severe malaria team at MMV to prepare this meeting. Thank you.
Yes, please. Thank you very much, Stefan, for that. Phyllis, you may join the dais for the panel discussion. I would like to request the representatives of the NMCPs from Cameroon, Kenya, Nigeria, and Sierra Leone to also come up and participate in the panel discussion. So colleagues, please come to the stage. So as we wait, as our colleagues join us on stage, are there any questions or clarifications that any member of the audience would like from the two presentations that have been made? Okay, go ahead.
Thank you. Again, I'm Beata, working with USAID Rwanda. I have a question for Phyllis. I saw in your presentation that at A28, we had a lot of positive cases for malaria in the 3 countries. I wanted to cross-check if you were able to look at if between those who were able to follow correctly the treatment and finish the whole treatment, and those who were not able to do it, because in your presentation you were able to show us that some children were referred but didn't go, and let us know if there was a difference between those two and what you would recommend to the countries and malaria program to be able to follow the treatment correctly for those children who received the rectal artesunate. Thank you.
Okay, thank you for that question. Any other? Okay, go ahead, Caroline.
Thank you so much for the presentation. Phyllis, I have a question. I wanted to just find out for those children, I think it was an example in Nigeria, those children who didn't go to the health facility after receiving RAS, did the community health worker give them anything? Or did they just leave them like that? Okay, the question is, did they know that they didn't follow up by going to the health facility? And then the other question I had was, I noted you said that a lot of patients actually went to the first level health facility in Nigeria, and they also were not given ACT after that. Is that the policy, or is it because of availability of commodities that could have led to that?
Thank you very much. My question is also to Phyllis. So I notice, and it's really good, every time I hear you make this presentation, I spot something new. So you talked about plus or minus IV artesunate on referral. Does this speak to a misclassification? Because as I understand it, the rectal artesunate should be pre-referral, and they need to go to a health facility and get parenteral treatment before they get oral ACTs. So does it speak to a problem with classification of severe malaria? So that's the first question. And then the second question is within the broader context of Uganda and what we're discussing at lunchtime, this longitudinal study where then there were signs that artesunate was failing. How much of the results you see is attributable to questionable or questions in the efficacy? I'm not saying it's failing, but how much of your results are attributable to that?
Specifically, we hear from the countries so that you may get some of your answers from the country experiences. So go ahead, Mike. And then we'll take some responses from Phyllis. Yes, you.
Sorry. Thank you so much. Yes, my question is still on Phyllis, on the Karama. It's an interesting one. But it's quite clear that it was a system issue throughout. And I don't know why the impression that came out was that rectal artesunate was not effective. I think. Yeah, but while doing that study, did you try to understand why the referral from the community was incomplete? Because this was there was an issue with the referral, incomplete referrals. What were the major reasons for these incomplete referrals? And then from the facility level, from Uganda and Nigeria, they were mostly given simple prescriptions. Is it the system that is there that patients have to buy, or is it a broken system of supply chain system? And you said 223 children died out of 13,000 that were followed in this study, representing a 0.02%. I'm wrong? You calculate for me. Okay, 223 out of 13,000. Out of 6,000. Okay, that now makes the percentage higher. Out of 6,000. Okay, fine. Then, of course, we don't expect any patient to die. But, yeah, I think let me drop that one. Thank you.
Thank you very much. So Phyllis, maybe go ahead. If there is part you feel the country teams can respond to, maybe you can defer to them. Thank you.
Thank you. I know, and that's why these results are presented to this audience. They are extremely relevant for all of us, and certainly I think there needs to be a lot more discussion beyond the short Q&A we do. So I'll try to answer most of the questions. I took note. The difference between the two groups, those who received rectal artesunate and those who didn't, you were asking about the high day 28 positivity. I'd just like to add another dimension that actually the general positivity even on, so we did household surveys as well every year, and to understand the malaria positivity, the prevalence of malaria in these children. And it's all very high. So children who are not sick and at home, literally at least half, 50% of children that we visited had positive malaria tests. So literally the pressure is very high in the community. So adults and children certainly have positive, malaria parasites running in their body. And so I think it is twofold. This was due to existing pressure really in the community, but also possibly due to incomplete treatment and the like, so circulating remaining antigen. But your question on the two groups is, yes, we have tried very hard, and I can't give you the answer directly, and I can look into it again and ask you about those two groups, those who got rectal testing, those who finished referral, I think, and those who didn't, and if there was how different is the positivity on day 28 in these children. Okay. All right. Nigeria and children not getting to a health facility after receiving rectal artesunate. I'm sorry, I just wrote the comment, but I didn't get it. You're asking why didn't they, or what were the reasons? What did we find around the reasons why children do not go to health facilities after referral, right? So we didn't do much qualitative interviews or exercise around Caramel, but we know for sure that the decision to go to a health facility, even if you've been referred, depends on many other things, you see. So it's not just that you get a referral note and you must go to a health facility, but there's a lot of other factors, all social factors, family's ability to pay for referral, to stay in referral, lost time for caretakers, and all that. So there's many reasons, and there's not one specific one, and it also cannot be directly solved. The best thing would be to have emergency referral transport, and we've shown, with the other studies, that when you have emergency referral transport, children get to the health facilities. And that was not the situation in the Caramel study, because normally that emergency referral transport is not there anyway. So really, that's all I can comment on that. All right, I'll skip. And Nicole, at the back, you were asking about misclassification. There is no misclassification. Maybe I said something wrong or you heard wrong. But indeed, the rectal artesunate is pre-referral. And the recommendation is really, as pre-referral medicine, you can give IM artesunate. If IM artesunate is not there, give rectal artesunate and refer immediately. So it's the recommendation, and maybe you saw something wrong or didn't. Well, we can talk a bit afterwards. And then you're talking about how much of our study results are attributed to artesunate failure. I think what I'd just like to make a general comment is that what we really find is more of a monotherapy perhaps contributing to resistance that is being seen maybe in Uganda. I know we'll talk about resistance later in the next panel. But we didn't do any efficacy studies in Caramel, so I don't want to comment on that. I don't have the data to comment on that. So we can also talk afterwards. Again, I think I discussed major reasons for referral completion. Facility level prescriptions. Okay, so the last question was about why are children getting prescriptions instead of the medicines? I think as National Malaria Control Program teams, we all know that the supply chain is the biggest challenge, the lack of medicines. And when they're not there, certainly a sick child will be given a prescription so that they can buy it. And then we don't know what really happens. In this observational study, all we can ask is, did you get the prescription? Did you actually get it? They could say yes or no, but we cannot confirm that they took the medication, that they bought it and took the medication. So the issue of giving a prescription is really because in the health facility there's no medicine. Sometimes in some countries they claim the health workers are stealing the commodities, but there's really no medicine to give the children. And I'd like to stop there.
Thank you very much, Phyllis. So we will kick off this discussion. Perhaps Nena will put you on the spot. Maybe. I know, and we're really grateful to the Nigeria Elimination Program for actually accepting to be part of Caramel and also TipTop, and the lessons that have been learned from this. Going forward, how do you see, community case management of malaria and pre-referral treatment for malaria? What do you think we need to work on in your program to ensure that the desired results are achieved?
So thank you, Elizabeth, and thank you for the presentation. Forgotten her name anyway. For that, Phillips, for that presentation, yes. So I actually wanted to, even before you took me on the spot, I actually wanted to also add to why maybe would have more of prescription given to these patients than, giving them the medicines itself. Because I just wanted to also underscore the fact that this is at secondary/tertiary health facilities. Management at that level for severe malaria is at that level. And for us in Nigeria, we actually don't have, even if we know that some health facilities will be doing drug revolving funds, but it also is attached with, there's monetary attachment. Unlike in PHCs, where there are a bit of free commodities for ACTs. So, for these patients, if it were to be at the PHCs, of course you dispense that ACT for them to go home with. But then at the secondary and tertiary, because of the drug revolving for some health facilities that have that, it will be a prescription. And remember that at this stage, most patients too that come down with this severe malaria are also patients that are not very well off, unfortunately. So we know, like she rightly said, a whole lot of other factors are also attributed. But then also coming back to what Elizabeth asked, yes, one major issue for us in Nigeria is the fact that, yes, we all participated very well in the RAS study, but up till now, I can say that we actually don't have RAS in country in terms of, I don't know, in the public setting, majorly. I know that the country had gone as far as forecasting for rectal artesunate, and I also know that we had gone as far as review of our guideline and, obvious dissemination to the right stakeholders, and also advocacy to the states to further disseminate down. And I just want to say also that the review of the guideline, which is the 4th edition and has captured the issue of RAS, it's what we're advocating to stakeholders, please disseminate further down, okay? But then why at the community that we're not having this is basically because of funding, majorly, but for us as a program, we've gone further to do a forecasting, for the community, for us, and so we're hoping that these are one of the things that will be strongly put on the table, across board all our partners, for Global Fund for the next funding season, and also other partners of ours. Maybe I'll stop there for now. Thank you.
Thank you very much, Nena, for that. And colleagues, we've been presented a challenge, and maybe hearing, I'm sure Nigeria would like to hear from you as well. If we say severe malaria must be managed at tertiary level, and tertiary level requires costs for case management, how do we reconcile the two? And how do we support care at the primary care level? I think these are some things the program and also our partners can help us think through. I'm coming to you, Anita, and this is Sierra Leone. It's not relevant for this meeting, but a question was asked. Sierra Leone has a strong community health system, and they are one of the countries that have nationally rolled out community IPTP. However, we also want to hear about your experience in the rollout of ICCM, including rectal attestunate at community level, how that has gone, and whether the challenges that have been reported today are things you have experienced. Over to you.
Thank you, Elizabeth. It's unfortunate that for Sierra Leone, even though we have quote-unquote strong community health systems, for RAMS, we normally call it RAMS, rectal attested malaria suppository, because in our country, when you say RAS, it's an abusive language. So we have to adapt to our own context. So for RAMS, we've not started at community level for obvious reasons. You know, in our country, we started it from the PHU level, the peripheral health unit level, which is the former health system, where the staff have been trained. For community levels, we have a high rate of rape cases in our country. And when you look at the community health workers program, we have more of men. And culture will not allow us for us to introduce it at that level, otherwise we'll get a backlash. So we decided as a program and as a ministry that we just start up with the health, with the PHUs, peripheral health units, and just forget about the CHW for now, community health workers for now. So at the PHU level, what we have been doing, it will be up and running. We have RAMS. As I'm speaking now, we have distribution going on for RAMS, which will be provided by PMI. But the issue we are having is at the secondary level. We, as a country, we are not prepared. Because I'm speaking, for over 2 or 3 years, we have not trained our health workers on severe malaria management. So we're having a lot of issues. It's only now that we are planning to do a training. So inserting the RAMS and refer them to the tertiary level or district hospital, we don't have the staff with the requisite capacity to handle those cases. And even the system is not ready. Because you think about blood transfusion, we don't have. We ask patients to, when you have a case, the parents will go and get the blood. We are not ready. The blood bank is not fully functional. And you also think about other things that you may need. Oxygen. It's not available. It's not always almost available. So there are lots of health systems issue with the case management treatment in our country. There are a lot of issues. We are trying very hard to push forward, but I know we'll get there, but it's not easy. Even the other treatment, it's not only injectable testing that you need when it comes to severe malaria. You also need other treatment, like anticonvulsants. We don't have. You have different needle and syringe cannulas. They are provided, but they are very small in small quantities. And the malaria burden in our country is very huge. So these are the things that we are really trying to work towards. Because referring cases is good, but we don't have what it takes to treat the case at the tertiary level. It's only now, as I say, we are planning to train the health workers, the medical doctors, and the senior nurses on how to manage severe malaria cases. Even that we want to train them, whilst we look for other things that we go with the package. Because the training of severe malaria is a package. If it's not available, then we're in trouble. So that's where we are for now, honestly, in Sierra Leone. Over.
Thank you very much, Anita. And that is the reality. So in as much as we sometimes at high level think that maybe there is just one solution, you realize that the challenges are numerous, and we will continue. So colleagues, hold your thoughts, and hopefully we will also hear from the audience. And I now want to come to you, Gladys, and Cameroon, the experience. You can speak in whichever language you're comfortable in. And I just wanted you to share the Cameroon experience. Basically, whether RAS has been introduced, how are we managing the supply chain for commodities, for malaria case management at primary care level and at community level? What is your experience with that? Thank you.
Okay, thank you, Elizabeth, for giving me the floor. Actually, we are just about to start with RAS in the country. We have the community workers who were trained, and during the training, or the retraining, the refresh courses, we spoke to them about artesunate, the rectal artesunate. So during the training, we told them rectal artesunate is not the treatment for severe malaria. It's just to give the child the chance to get to the health facility. So we asked them to communicate with the mothers or the caregivers on the fact that this is not the treatment, but it's just to help the child reach the health facility alive. So during the communication, they will not take it as if it is the treatment. That is to help the child reach the hospital. And in the hospital, what is given as guideline is that each child who is referred by a community health worker or somebody working in the health facility at the lower level should be taken care of with injectable artesunate before going to ACT, to oral ACT. So this year we have started. It's true we had a slowdown because of these results. They came to us as RAS has a problem, so we had to slow down a bit, but we received recommendation that we need to align to the guidelines. So we started again, and we are starting with two regions, the northern region and the far north, where we have the highest morbidity and mortality to the less than 5. And another thing I would like to say is we have 2 decrees asking the health facility to take care of the children free of charge. The less than 5 are supposed to be taken care of free of charge, which will make it easier when a mother is in the health facility to receive the treatment. It's true that only a certain percentage, maybe 45% of the prescriber would respect this prescription, because at times we have shortage. We don't have enough injectable artesunate at times, and they need to take care of the children with another molecule like artemether or quinine injectable, which are not subsidized. And if it is so, the parents or caregiver will need to pay for that. So that is the main problem we will have with the care of the less than 5. So we do hope that we will strengthen the procurement system, and that will have enough drugs. And another issue with injectable artesunate is that it's being overused. In the beginning, the health practitioner was a bit scared when it was new, but now they are really, they have confidence in injectable artesunate, and they are using it more than enough. In some of our health facilities, more than 70% of the cases are severe cases in bracket. But when we go for investigation, we discover that they are taking injectable artesunate, maybe because they prefer it, or because it is more rentable than any other drugs, because it is subsidized. So this will lead to stock out of injectable artesunate also. So these are our main challenges. They will make them understand that RAS is not a panacea, it's just a way out, because at times distances are far, and we need the children to be protected. Thank you.
Thank you very much, Gladys, for that experience from Cameroon, and emphasizing the importance of communication and also highlighting the issue of overuse of injection artesunate, which I'm sure many countries have experienced or are experiencing. So coming to Kenya, Dr. Ahmedin, you've had issues about quality of care, completing referral, and children or patients with severe malaria arriving at the facility and getting the appropriate care for severe malaria. What have you done in Kenya? What is your experience with enhancing quality of care for severe malaria to ensure adherence to guidelines? Is this still a challenge, and how are you addressing these challenges? Over to you.
Thank you very much, Dr. Elizabeth, for giving me the opportunity. On the issue of, first, I would like to first start with the rectal attestation discussion that has been going on. And in Kenya, unfortunately, for I think close to 10 years, initially we had even put it on our strategy that we have the rectal attestation as a referral pre-referral treatment. However, the availability was a big issue. So we even had to remove it from our Kenya malaria strategy that was revised in 2019. Now in the midterm review, we have to again put it back because we are being told that the companies that are making it now, the availability might improve. On the issue of the health, once a patient, for example, with severe malaria is referred to a health facility, there has been issues with how the patient is managed in the health facilities. The quality of care, starting from how this patient, from the diagnosis, from the treatment, from the testing, those who are positive being treated, or those who are being seen to be severe being managed accordingly. To the health workers have been having an issue even with big challenges in terms of knowledge and skills in constituting the artesunate injection. Also, the health workers have been having a very big challenge in terms of the triage, such that patients who really need help, who really need to be seen first with severe, end up, behind the lines and being maybe end up as losing the patients. So what we have done is that we're trying to, we're trying to encourage. We have changed our capacity building approach. Previously, we used to have off-site trainings whereby health workers from different health facilities are brought to a central place the way we are brought here and we are trained. Currently, what we are doing is that we try as much as possible to do on-job training. So we try to ensure each sub-county, or what you call a district, have masters or mentors or master trainers who will be able to move and train health workers who are working in the outpatient department, in the emergency department, in the wards, the medical wards and the pediatric wards, to ensure that the health workers learn on job how to reconstitute, how to calculate the dosaging, how to treat the patients, and how to ensure that, because adhering to the national guidelines is a composite, is a whole thing, from the testing to the diagnostics to the now how much the amount of the dosaging, how much do we need to give, reconstitution, giving the right instructions, follow up. So and all these things can only best be practiced, trained to the health workers while on job training. So forget about the community level, at the health facility level, there is a big issue in terms of knowledge and skills that needs to be taken care of. Thank you.
Thank you very much for those interventions. Stefan, having had the interventions from some of the countries, in addition to what you had presented from Zambia, from the experiences of other countries, what are your thoughts overall? What do you think? I mean, you gave us good conclusions, but do you have any additional thoughts to add, given what we've heard from the countries represented here? Over to you.
Yes, thanks for giving me the floor. Just would like to add a few points. First, we avoid, maybe you have seen on my presentation, we avoid to use rectal artesunate treatment because, as it was said from Cameroon, we want to stop mixing the head of the people. They need to understand it's not the final treatment, and it's just a commodity that will help them to survive and to go to the healthcare center to be treated with a final treatment. So I think that will be important to avoid this word treatment when we speak of rectal artesunate. Second point, there is something which is also important, is the fact that in some area, people, and it was said this morning, some people can receive rectal artesunate, but after cannot be referred anywhere. So we need to continue rectal artesunate until they can take orally the SCT. And at MMV, we are discussing and thinking of maybe having some study comparing what's happened in patients having had the full referring with rectal artesunate, injectable artesunate, and the 3 days of ACT, in comparison to patients that will be in area where they cannot be referred and where they only receive rectal artesunate followed by ACT. And in addition to what has been done in Caramal, we would like to do some efficacy and resistance work to see if it has any impact regarding these 2 points. So that is something we are thinking of at MMV. It's just the start of the thinking. So I don't want to tell you it will be done, but it's something that we think that could have some interest. And I already spoke with Phyllis, and I'm very happy to discuss with anybody on this project to see if you believe it has some interest. And in case we go ahead, if you would be interested to go in the study with us. Thank you.
Dear colleagues in the audience, I feel like we need a whole day to discuss severe malaria. I think the challenges and the issues that have been presented by the countries, and this was really a random selection by myself. I'm sure there are other countries, colleagues who have their own experiences that they would like to share with respect to severe malaria. But today we will give our colleagues an opportunity. Does anyone have a comment or a question that they would like to ask Sierra Leone, Cameroon, Nigeria, or Kenya? So yes, Dennis, go ahead, and then Peter. Not yet. Your microphone is...
Team, and it's good I've had experiences from other countries. Of course, I have mine, and time cannot allow. But from the presenters, they have talked of particularly the government health system. I have not heard of private sector. Like, for example, how is severe malaria managed? You have been talking of referral with rectal artesunate. Some end up in the private sector. But they have not talked about experience in private sector. For example, in Uganda, more than 60% of malaria patients, even all patients, are managed in the private sector. And by policy, severe malaria, IV artesunate, and now we also have quinine, is at a health center 3 and above. But in the private sector, they treat some forms of severe malaria. And I know when you were writing the concept note, Global Fund, I struggled a lot to subsidize IV artesunate for private sector. And though it's our first priority in severe malaria, but in the private sector, it's very expensive, and they opt using quinine. So what is the experience of other countries? Because Global Fund refused to subsidize, that by policy, health center tools are not supposed to treat severe malaria, and the majority of private sector are at health center 2 level. Over.
Thank you, Dennis. We will have them answer. Peter?
She's not seeing this side.
Thank you very much. I think mine, it's maybe more of comment, too, and maybe a question. And Felix, first of all, to do with the study, I think, just like you said, this was an observational study. And we should always put that in context, because there are some conclusions made which the observational study cannot really arrive at those conclusions. For example, when you say that the introduction of RAS might have affected the referrer, but you never investigated in this study factors that affected referrer. So we can't make such conclusions, because it's challenging to countries. It's challenging to, it's an observational study. You didn't do anything. The fact that people go to the health facility and they did not get ACTs and all of that, you didn't investigate any of that. And it was not peculiar to people who were on RAS. If they did not get ACT, that means people who went to those facilities for treatment did not get ACTs. You just observed different time points and so many other contextual factors which were not investigated. So I think we should put all of those in context when we are given the summary and the end result of the study. And that's where the challenge is, which gives the impression as if the problem is RAS. But this study never did any of those. We just observed, and so, and I think that should reflect in the presentation the limitations of the study as an observational study and the conclusions derived from the studies. That's one. The other point I want to make, and I think it's very clear from the countries presenting, see, unlike things like bed nets and all of that, when it comes to case management, the national program, you do not deliver case management. Case management is part of the health services in the country. And so when you say, for example, in Sierra Leone, there are no needles, no syringes and all that, that's not malaria specific. That is a challenge in the system. And the malaria program, you can do nothing about that, except to find ways to connect to strengths. And I want us to put this in context when we are looking and discussing most of these issues. But what you can do, and what I want to encourage here is, for whatsoever reason, and you identified it, over the years, we dropped the ball when it came to training. We used to do systematic training of health workers, case management training. The last I can remember was Botswana not too long ago, out of the blues. But in countries, it stopped completely. It was one part of a package. You did guidelines, what have you, training materials are developed, we do training of trainers, and that just got lost. And I think programs need to revise that and bring that back. Money will always be an issue, but if I ask how many countries here have a case management training plan? If you don't have a plan, then what will I fund? So I'm using this to encourage us to get back to training our health workers, just like program managers are changing. When people were introducing today and we were saying, I'm the case management focal point, I said, because I used to know all case management focal points, but now I don't know who case management. So the same thing is happening among health workers, and the need for continued training of case management across the country. So I think those are just the comments I wanted to make. Thank you.
Thank you, Peter.
Can she see?
Oh, okay. Oh, wait. Let her go first, and then I'll come to you.
Thank you for the opportunity. Just to piggyback on his comments with training. I am from Liberia, and we have a lot of issues if it comes to Global Fund. We talk about training. Training is very essential. But then the LCM comes and says, we have had so many training, and we don't need training. But training is very essential because we have attrition of staff. We have people coming in, people are leaving. And so people actually need to be trained. And so I just hope that people that are watching from afar, people in the room from Global Fund and other places know that we actually need training. We need training. People need to be trained. People leave, people come, and they need to be trained. But my main question has to do with Nigeria if it comes to revolving drug fund. Revolving drug fund, yeah. I know that we are subsidized or probably given free drugs with malaria commodities. And so if we are doing revolving drug fund, I thought there should be some dispensation given to certain patients, like for revolving drug fund from where I come from, the under 5s and the pregnant women. And if it comes to malaria commodity because they are being prepaid or they are being bought by Global Fund, I thought that people that go to the facility should have free medication, unlike the private facilities that actually sell the drugs. And so Global Fund actually do not support that. So if you talk about revolving drug fund, I do believe that there should be dispensation given to certain patients if it comes to malaria commodity. Over. Thank you.
Thank you very much. Caroline, I think that will be our last so that we give our panelists an opportunity to respond.
Thank you. I've got a question and a comment. I'll start with a comment. My comment, I think, is towards what Anita from, is it Sierra Leone mentioned? I think she's the one who talked about the SBC part. I just wanted to say that I think that's a very important part as we are introducing, as we are rolling out the RAS, the SBC to the community, and the importance for us to actually always tell them that it's a pre-referral support that we are giving and it's not treatment. Because at times, I think we start a program and introduce it, and then maybe that's why we see that the patients do not continue with the referral. My second question is what I had asked earlier. I think it was not understood. My question was, for those children who were not taken to the health facility, I believe the community health workers live with these families, and they know that this patient came to me and this patient did not take the child to the next level. What did they give those children? Were those children just left like that? Was there anything done to those children? I think that's what I was asking about. Was what alternative did they give? Just want to hear what the community health workers did. Thank you.
Thank you very much, Caroline. Actually, the SBC was mentioned by Gladys from Cameroon, so yes. So thank you very much. So we will start with the private sector question, private sector experience with the, that Dennis asked from Uganda. What is your experience with case management or even referral to the private sector and subsequent management? So very briefly, we'll start with you, Ahmedin.
Thank you very much. I think private sector plays a big role even in Kenya. Up to 40% of health workers, of patients go to private sector. Especially with over the last 2 years due to COVID, the numbers have even increased. So for the private sector, for Kenya, what we have tried to do is we want, because private sector is a completely different entity, what we have tried to put in place is we supported them in training, in capacity building, also to ensure that we monitor the way they are there to the guidelines. We have put in place what you call private sector quality of care surveys that we do every 2 years. And we ensure that there are no monotherapies that are given, whether it's a small retail outlet or whether it's a tertiary level university private sector. So we try to do that. However, I just wanted to move also on to the training aspect. For the training, it's true, most donors are not very happy to continue training. So we have to devise, and also, of course, health workers keep on moving and the attrition is there. So for Kenya, one of the things that we have done is we have tried to align the pre-service curricula, what is being taught in the colleges, in the universities, in line with the what do you call the guidelines that we have, to ensure that, because you realize most of the universities, what they are teaching, most of the college, what they are teaching is completely out of date with what is currently being practiced in the national guidelines. So we have done updating of the pre-service curricula. We have involved lecturers from these places. We have involved professors from the tertiary levels, and their involvement or engagement is different from how you engage a health worker. You have to be very respectful, and you have to, it has to be an exchange sort of program, and it has really worked, and it's working very well. And for Kenya, because the funding is not available, what we have done is for each district or each sub-county, we support 3 what you call TOT or master trainers. We also support them to go around health facilities, identify key gaps which health worker needs to be trained, and then they are given on-job trainings. And we also provided, through support from some partners, an e-learning platform for any health worker, whether it is for uncomplicated or complicated malaria, and they get CPD points for that. So it encourages them, it reduces the costs, and we are slowly seeing the improvement in terms of the quality of care that's being provided. Thank you very much.
Thank you very much. Nena, you have your private sector experience, as asked by Dennis, but also a bit more. Our colleague from Liberia is concerned that your revolving fund in tertiary level does not cover under 5 and pregnant women. So a bit more explanation on that. Thank you. Over.
So thank you very much. Starting with the private sector, yes. For us in Nigeria, we also have that or recognize that gap, that the non-adherence to the choice of drug in terms of severe malaria management is also worse in that sector. And that's why, like my colleague had talked about, for us in Nigeria, we had also started looking at such measures involving medical associations. Like I said, when we reviewed, the guideline, we had stakeholders, come to table, and stakeholders meant people from the private sector, people from the medical association, because we realized too, that knowledge gap. What we have now in the guideline is totally different from what is there in the schedule or in the scheme for in-service training, both across board for medical doctors, nurses, and even laboratory scientists. So that we know, and so we're working closely because of that, and because we know also that the private sector has huge patronage. We also have started at that lower level to, push more of quality of care trainings, So we're doing that, we're about doing that in 5 Global Fund supported states to train PPMVs and CPs, community pharmacists, on, quality management for malaria at that level. So it's all because of the gap, the knowledge gap that we have realized that we're taking such measures. It's also important going by training, just like when my colleague from Liberia was like shaking my head, because training is it. And we know, attrition, and the fact that there's a huge gap from what we have in the guideline and what these medical students and all that are being trained for. Like, for example, lately, after we did dissemination and, like we said, continued advocacy down for states to further disseminate to LGA level, and what we did for dissemination was to bring out the key things that, had evolved, both on areas like severe malaria, malaria in pregnancy, what is the management like? So these are the things. So what we did was to, when we did train for PMI-supported states, like last month, some of these consultants were like very excited that they did this, they had this. So you cannot, underscore the importance of really training. So we are hoping that partners, together with, of course, the program will come together and really look at this issue of continuing training as key to get it right. So also talking to my Liberian counterpart or colleague, in terms of drug funding, revolving fund, at that level of secondary and tertiary, I know that these are what health facilities kind of, will I say, out-of-the-box kind of strategy that they use for availability, of commodities and accessibility of commodities. So like, monies are being pulled together. It's not exactly being championed from the program. Okay, so these are what some health facilities, and that's why you don't have it. You have it, scattered. It's not, in every health facility. So the essence is just to have a pooled resources and make these commodities available. And then, at this level too, these commodities are also prescribed. The patient, they give prescription to these patients because they have to buy them, even though they may be a little subsidized because they are buying in bulk, but just to say that it's not the program that is championing this. It's just something that the health facilities do. And we think it's a good idea because you find out that the drugs are readily available at the health facilities and they're also accessible, So that's what I would say at that. Thank you.
So Gladys, very briefly, the private sector. Mm-hmm.
Ok, merci. Je vais parler cette fois-ci en français pour dire que le secteur privé a un rôle important à jouer dans la lutte contre le paludisme et dans notre subvention actuelle, il y a tout un volet qui est réservé au secteur privé. Au départ, il s'occupait du VIH, sida et de la tuberculose et depuis 2 ans, on a inclus le paludisme dans le paquet qu'ils ont à prendre en charge. Mais je voudrais aussi dire que nous avons 2 types de secteurs privés. Nous avons le secteur privé à but lucratif et le secteur privé à but non lucratif, c'est les hôpitaux confessionnels. Et ceux-là reçoivent aussi les médicaments subventionnés. Donc le privé à but lucratif ne reçoit pas des médicaments subventionnés, mais les privés à but non lucratif sont plus ou moins comme le public. Et donc, ils sont impliqués à tous les niveaux. Quand il s'agit de former, parce qu'après la revue de nos directives en 2019, pour revenir à la formation, effectivement, nous avons fait une formation sur tout le territoire. Nous avons formé seulement 3 000 sur 6 000 prestataires, mais cela nous a permis de couvrir un certain nombre de FOSA et il leur a été demandé de repliquer la formation à leur tour. Et à côté de cela, nous nous sommes rendus compte que la formation théorique ne suffisait pas et nous sommes en train de mettre sur pied le système de mentoring qui fait que nous formions des personnes au niveau central dans les CHU qui sont surtout formées sur la prise en charge des complications. Ils sont relâchés dans les régions et font des supervisions dans des formations sanitaires où il y a des problèmes. Et à ce moment-là, ils forment ces personnes à la prise en charge et à la prévention des complications. Maintenant, comme mon collègue l'a dit, on intègre aussi le cursus universitaire où on rattrape les étudiants à la fin d'année de formation, presque à la fin, et on leur parle du paludisme parce que ce qui est appris à l'école, on s'est rendu compte, est différent des nouvelles directives. Donc c'est un peu comme ça que nous essayons de les rattraper. On ne le fait pas encore dans toutes les écoles de médecine, mais au moins celles qui sont accessibles. Et on profite aussi de l'opportunité des symposia. Donc chaque fois qu'on a une opportunité de réunion, dans le pays, nous parlons des directives de prise en charge du paludisme. Je vous remercie.
Merci. Merci pour votre intervention. I now call upon Anita, please.
Thank you so much for giving me the opportunity. It's a very interesting discussion about the private sector. Private sector, they are part of the system. You cannot turn away from them. What we are doing in Sierra Leone is that we have private hospitals that we normally support with our commodities, be it RDT or ACTs or inject, whichever. We provide them free of cost. We ensure that they have an MOU that they sign with the Ministry of Health and Sanitation. And they have been monitored because we know that they are private people, they want money. But for our commodities, we monitor them. Because if you just leave like that, leave them with those, they will charge the patient, but we ensure that we monitor the commodities. Why? Because there are a huge number of people going to the private sector who are also part of the country, Sierra Leone. So we ensure that we monitor, put systems in place to ensure that what the policy says, what they are doing. Another important, interesting group that we are also working with the private pharmacies. In Sierra Leone, we started this about 2 years ago. We involve our private pharmacists in our malaria control interventions. In Sierra Leone, most of our people also go there, like not even the elite. Some of us, we just go to the pharmacy, buy medicine because we want to waste time. You just park your vehicle, buy whatever you want to buy, you go. It's common among everybody. So but we realize that this number, we cannot let it go like that. They need to follow the policies. So we have a consultative meeting with the pharmacists, Pharmaceutical Board of Sierra Leone, Pharmaceutical Business Association. We had a meeting, a consultative meeting, and we brought out our policies and guidelines. And they thought it fit that they need to follow that. But it's a win-win situation. We provide just the RDTs. We provide our RDTs free to the private pharmacies. Those are registered with the Pharmaceutical Board of Sierra Leone. We provide RDTs to them. They ensure that they do the RDTs free of cost. We are also monitoring them. But for the ACT, there are the caveats. For the ACT, if you go to a pharmacy, walk into a pharmacy, they do a test. You can either buy the ACT from them or you go and get it from a health facility that provides it free. Because you cannot tell them to give everything free. RDT is free, but it's left with the patient, whether to buy from you or I go to the facility where it is being provided free. We have that understanding. And it has been working well for the past 2 years. It has been working well. So that's what the malaria program is doing, and we are monitoring that. Let me just briefly mention something on training. Yes, for quite some time now, we have not been doing trainings. You know, one thing in life, we should not allow, even if you are the head of a household, don't allow somebody else to come and take responsibility of your house. 100% responsibility, there will always be a problem. That's what we are faced with our donors. Because he who blows the pipe chooses the tune. But again, most times I blame our government. If this donor say, okay, I don't want to do trainings, I want mentorship, let's forget about trainings. What are you doing as a government? You want training. Why can't you support the country to do the trainings that you think you need? But we put all our eggs in one basket. Governments have devolved themselves from their responsibilities. This is why we are faced with a lot of problems. It's the same thing we face with. Again, what we are doing as a program, we ensure that we are aligned because we know that we have a lot of attrition rates. People are being transferred. People go for greener pastures in our facilities. So we ensure that we align our guidelines with the curriculum of the preschool's curriculum. So that at least when they are in the final year in their schools, they will be taught something on malaria. So by the time they are off, because we don't have trainings, by the time they are off,
very fast, then I can give Stefan and Larry to wrap up. Your microphone, please.
Yes, thank you, and I will comment on the two questions that were raised. Let me start with my colleague on this side, and I'll end with Peter. So you asked that what happened to the children who did not go to a referral health facility. What did they receive? So that analysis on referral really is focusing on children who reached a referral level facility. You get it, where we believe there is capacity to manage additional complications of severe malaria. So when we say about 60% of the children actually completed referral, we mean they went. That doesn't mean that children were not treated at the lower level where they could have stayed or could have gone. If a child went to there's a level in between a health post and a referral facility. If a child remained there, there are actually sometimes health workers that have the capacity to manage severe malaria, or they can. So these children actually got some treatment. We said 30% went to private health providers. We said, and I know that some of them were treated at a. The concluding slide actually said that we have an efficacious medicine, rectal artesunate, and we were not able to see its full effect, given all the health system deficiencies that we saw in the system. And so when you have an observational study, as we all know, we can only get ideas on what are possible causative relationships. We are not saying there's a direct causative relationship because we don't have the study design to do that. But if you see something like the reduced referrals in children who have got rectal artesunate, I mean, we need to just step back and think, okay, is there any plausible possibility? And there could be. Certainly children get a little better, maybe they didn't go, but this is just a step one in if we need to, then we need to continue and do a different study design to understand actual referral in relation to the use of rectal artesunate. I personally, as part of Caramel, completely agree with you that, the study design used does not give us a causative relationship, but the study has been useful enough to show us the deficiencies that we find, and is an eye-opener. And if we would like, we can continue additional research in those areas that are contentious, because they have been contentious throughout Caramel once the results started coming out, and really more can be done with better study design. So for me, I fully agree with you, and I'm happy that you people didn't change the guidelines, really, because it is an efficacious product that should be available to children, and we are just providing evidence to help us all use the product better. Thank you.
Thank you, Phyllis. Stefan, last words?
Quick word. So I think that rectal artesunate is a very important tool for the management of severe malaria, but it must be integrated in the health system, as we said. So if there is anything missing from the community health worker, which need to be properly trained, and also the wordings that are used, as patients need to well understand what it means, and after you need to have a good care facility where patients will be treated properly with injectable artesunate, and after you need to have the SCTs available. So I hear everywhere there is, not everywhere, but in some places there is some points which are missing, and it cannot be successful if any of these different points are not present. So
Pascal, are you on the line?
I am on the line. Can you hear me?
Yes, we can hear you. Okay, we'll be with you in just a minute.
No problem.
Okay.
The problem is that my video is not working because I'm not allowed to turn it on.
Okay. Well, we will mourn not seeing your face. But I'm going to hand it over to our chair for this last session today, Naomi Luki from PMI Rwanda.
No, thank you, Larry. So I'm looking around to see that everybody is back with a nice boost of coffee, because we're going to get into the drug resistance section this afternoon. I know we are tired. It's been a long day. It's been a very interesting day, so bear with us. This is just going to be 1.5 hours of very interesting stuff that's going on. So I'm sure most of you are aware of what's happening in Southeast Asia. It's been going on for a while. The question is, how does it look like? How is the platform right now in Africa? So I'm sure everybody wants to know that, because if we lose our key interventions, we are in big trouble. So we do want to see what's going on, what's happening, how do we move from here? So without further talking, Pascal, since you're on the line, we'll miss to see your face, but we are happy to hear from you. So I will be advancing the slides for you, or if you're able to do that on your side, go ahead, but I'm here on standby to advance the slides for you. Okay, you will advance yours and I will advance ours. We'll try to sync that. Okay, without further ado, everybody, back to drug resistance. So Pascal, take it away.
Thank you. So what should I do? Do you see my screen?
Yes, we do.
Or
Session.
you have your screen.
Oh, okay. Hold on. Okay. Those are your slides now, Pascal, so go ahead.
Okay. So with the first slide, which is just the cover of the meeting of RBM case management working. So we can go to the next slide. So these are just basic source of information for those who are not familiar. It's the way we are monitoring drug resistance and drug efficacy and drug resistance, and it's quite important to recall the way it should be done. This also for the future, and in particular in the strategy that we are developing, is emphasizing on the different tools that needs to be used. So first of all, we have, of course, everybody knows the therapeutic efficacy studies, which remain the gold standard, which every country should do. And according to our investigation, I mean, we have only half African countries that are doing regularly monitoring of the drug efficacy. And then you have additional tools which cannot be done in every country, because you need sometimes some labs with highly sophisticated material and labs. You have from the most sophisticated, which is in vitro ex vivo studies, and also pharmacokinetics, where you need to have HPHC for monitoring blood levels, which is an important tools to monitor if drugs have been well absorbed. And then the one that is taking more and more importance in monitoring and getting a better picture of the situation, especially in the continent, African continent, which are molecular markers. And this just needs a simple filter paper, but needs labs to conduct the study by different techniques, which also go from very simple ones, which are PCR, to very sophisticated, which are whole genome sequencing. Next slide. The next slide gives you the definition, which I'm starting by the well-known definition of anti-malaria drug resistance, which has its own definition, and we will see that artemisinin, what we see with the artemisinin, does not fit with that definition, but I will come later to that difference. So it's the ability of parasite to develop despite blood levels that usually kill the parasites. And this we know that we have seen that with chloroquine or with SP in the past. which the anti-malaria drug resistance is slightly different from a treatment failure, because treatment failure is the inability to clear the parasite, but there could be many causes. It's not necessarily due to the resistance. It could be many factors that contribute to treatment failures, incorrect dosage, and this needs training by the health workers, poor adherence treatment by the patient. This needs a lot of education, poor drug quality or drug interaction, and finally resistance. But TES by itself take care of many of these factors, whereas in real life, these factors are quite predominant and include treatment failures in the patient, and which leads after to kill this parasite, which progressively will have more pressure and will start to develop reduced susceptibility to the drug that we are using. Next slide. Now we are coming to the artemisinin-based combination therapy. So we all know that the artemisinin-based combination therapy is a combination of an artemisinin, which is reducing the biomass, which you can see in purple, massively reducing the biomass, and then you have the partner drug, which is eliminating the remaining parasites. Just to say that all the partner drugs that are used currently with all ACTs, all these partner drugs alone, except SP, because we know that there is high SP resistance in Africa and in many places of the world. All the other 5 partner drugs alone would be very, very efficacious, even if they were used at monotherapy at the dose they are associated with the artemisinin. So all the partner drug could destroy sensitive parasites, and the fact that they have artemisinin in addition to the partner drugs will, first of all, reduce more quickly the biomass, and then will make the work more easier for the partner drug. In fact, we could call this an anti-malarial boosted combination, because the artemisinin is boosting the partner. So in case of artemisinin partial resistance, the biomass will be less reduced, and this is shown in the next slide. So in case of artemisinin partial resistance, and we had a lot of discussion because so far it's only a partial resistance, because the problem with the artemisinin is only reflected by a decreased a delayed of the clearance of the parasite. But if you use a 7-day artesunate, even in the Greater Mekong, you will have more than 90% efficacy. So in other words, the problem of artemisinin is targeting only one stage of the parasite, which is the ring stage. And fortunately, the resistance or the mechanism of resistance has not extended to the other cycle of the parasites. So this is good, because as said, it's translated as a reduced reduction of biomass, a delayed clearance, but the partner drug, if they are efficacious, they will continue to clear the parasite. Nevertheless, the partner drugs, as I said, need to work more and is more exposed to emergence of resistance, or eventually to spread of less susceptible parasites to that partner drug. And on the right side, you see the figures. You see how this delayed clearance in the Greater Mekong increase progressively, because the parasites become more and more, let's say, less susceptible to artemisinin. So the delayed clearance alone does not lead to a significant increase of ACT treatment failure. But as I said, if they still put more pressure on the partner drug. But nevertheless, if you have artemisinin partial resistance plus artemisinin plus resistance to the partner drug, in this case, you will see very high treatment failure with an ACTs. And this we have seen in the Greater Mekong, but fortunately, we have not seen this yet in Africa. So just it's not possible to not show you some data from the Greater Mekong, because it's just to see what could happen, what we should avoid, but also not to raise panic how it was done in the Greater Mekong. So what we are seeing currently in Africa, this emergence of artemisinin partial resistance is a big concern, but I can show you that we have solution for that. So This is a map showing that when you have a combination of artemisinin partial resistance and partner drug resistance, you can see that the parasite resistance to both drugs are spreading extremely quickly. And this is due to several factors. But when we changed the partner drugs, and this is shown in the next slide, this is a slide which showed the situation before we changed the first line treatment. You can see that you have extremely high artemisinin resistance, 90%, and you have a very high level of piperacin resistance. But when we changed the policy in Cambodia and we moved to artesunate mefloquine for adults and artesunate paronaridine for children, which is a multiple first-line treatment, in fact, you can see that very quickly the artemisinin partial resistance parasite disappeared. And from 90% of parasite resistant to artemisinin, we ended up with 50% of wild type. And similarly, the piperacin resistance quite completely disappeared in Cambodia. Next slide. Similarly, this parasite, which as I showed in the previous slide, has spread from Cambodia to Laos. You can see before the policy change, you can see that they showed the same kind of figure, meaning very high artemisinin partial resistance prevalence and very high prevalence of piperacin resistance. But then when the country, which is not using, by the way, DHA piperacin, but artemether-lumefantrine, they just added primaquine as a single dose to kill the gametocyte, you can see that the artemisinin partial resistance progressively disappeared. We have now more than 90% of wild type of artemisinin sensitive parasite, and you see that the piperacin resistance completely disappeared. This is a little bit what we saw in Africa when we removed chloroquine. This is what we see here when we remove a failing drug. And then I have another example to show what should not be done. This is in Vietnam, where they had a very you can see exactly the same kind of figure before they officially changed policy from DHA piperacin to artesunate paronaridine, but you see that the marker of resistance didn't change. And this is for a very simple reason, is that because the country had still a huge stock of DHA piperacin, and they prefer first using the DHA piperacin rather than use the artesunate paronaridine. So this is really an example where countries are facing a problem. They should absolutely not delay the changing of policy for whatever reason, and especially not because they have still a stock of drugs that need to be used or expiring soon. But changing the policy is extremely important. And as you can see here, we have now fixed artemisinin partial resistance in Vietnam, and we have extremely high resistance to piperacin. So this is really a plea to the country that if they are facing a problem of resistance, they should change their first line. And as you have seen in Cambodia and Laos, we didn't need triple therapies. We just used very, very basic ACTs which were available, or adding primaquine. And this was largely sufficient to completely not only reduce the prevalence of resistance parasite, but also to reduce the number of cases. We have less than 4,000 cases now of PF in the 4 countries, meaning Vietnam, Laos, Cambodia, and Thailand. In the next slide, this is another example of how the country has dealt with artemisinin partial resistance. There was an emergence in Guyana. This was in a special area, which is called Region 1. We saw an emergence of artemisinin partial resistance, and the country put major effort of vector control and better case management in the Region 1, which is bordering Venezuela, and which is in a very difficult area of mining zones. And after extremely intensified efforts, this artemisinin resistance parasite disappeared. And since 2017, we have not seen this parasite re-emerging again. So again, this is a message of hope, but still, I think what is happening in Africa needs to be taken very seriously, and massive effort needs to be done in order to be successful, like we were successful in other parts of the world. So this is just the list. It's not a simple way to understand artemisinin partial resistance, because it's not like for chloroquine, a single mutant, the PFCRT K76T. Here for artemisinin partial resistance, we have a lot of markers, a lot of mutants that are involved in artemisinin partial resistance, which makes also the surveillance a little bit complicated. So we have 13 validated markers, we have candidate markers, but it's very complicated to monitor and to understand the problem of artemisinin resistance. Things are evolving, and our understanding is getting better and better. So now, what is the situation in Africa? Again, artemisinin partial, and I'm not coming back on this, has been confirmed in Rwanda, in Uganda, and they were not the same mutant that were found in Rwanda and Uganda, and also in Horn of Africa. The mutant that has been seen in the Horn of Africa is prevalent in several countries, but is really linked to delayed clearance in Eritrea. Nevertheless, we have a lack of geographical coverage. We do not have data for every country, so we do not know if these are the only countries which are affected with artemisinin partial resistance. The second is that the situation in Africa, because of the direct transmission area, it's slightly different than we see in the Great Mekong or in South America. The fitness cost and the genetic background, which are expected to play a key role, are completely different in Africa. There are much more parasites circulating. There are recombination in the mosquito of different clones of parasite. And therefore, the spread of resistance could be different than Greater Mekong. In the Greater Mekong, you had only clones circulating, meaning one single parasite circulating in the whole country. In Africa, it's multiple parasite, multiple different types of parasite infecting one patient. We know, and I will come back to this one, we have information about the drug in Africa, but we have scattered reports on treatment failure, sorry, but reports of real resistance to piperaquine, to pyronaridine, to lumefantrine, to mefloquine, and to a lesser extent to amodiaquine. It's quite limited, and we have not really confirmed to the partner drug, despite I need to reiterate, treatment failure have been reported. And then Africa is, since we changed from chloroquine to ACTs, Africa is not so much used to hear again about resistance. I mean, other areas like in Asia, they were quite more embedded in problems of resistance. And then suddenly we are raising an alarm in Africa that we have a resistance emerging, and we heard that there is an underestimation by local stakeholders that this is not really a problem for Africa. And I reiterate here, it is a problem. We are always, and WHO has always been concerned when we saw a problem of resistance, even if it's partial resistance emerging somewhere, because it has, in a way or another, impact on the treatment of patients. That's why communication and advocacy will play a key role in order to implement a strategy to fight against the emergence of resistance to either artemisinin or to the partner drugs. So on the next slide, this shows the country which are affected with artemisinin partial resistance. It's not only the fact that you have mutant parasite carrying a mutation and delayed clearance, it's also the high prevalence, which means that you have really a clonal expansion of this parasite, meaning this parasite, despite the fact that the ACTs remain highly efficacious, this parasite continue to spread. Sorry, and this is most probably due to the fact that this parasite have a capacity to develop more gametocyte than would sensitive parasite do. And I'm talking here about artemisinin partial resistance. Just to highlight that the mutation have not been imported from Asia. This mutant have emerged spontaneously in Africa. So they are African-born mutant, and this parasite, despite in these three countries they are associated with delayed clearance, the ACT efficacy in these countries remain very high. And here also, this means that despite the fact that you have a partner drug which is highly efficacious, and you could put 1, 2, 3, or 4, the artemisinin partial resistance emerged despite the fact that we're associated with a highly efficacious partner medicine. So now quickly, we could have multiple maps or whatever, but I think we need to focus on the 3 major partner drugs, amodiaquine, lumefantrine, and piperaquine. And amodiaquine, we must admit that since we introduced artesunate amodiaquine, and since artesunate amodiaquine was highly efficacious where it was introduced, the investigation on amodiaquine or studies on amodiaquine resistance were a little bit neglected. And we have since late or early 2000, we are quite ignorant on how amodiaquine alone is efficacious. And if we look at the WHO database on ACT efficacy, we can hardly find artesunate amodiaquine failing. We have one, I picked one, which is in Liberia. We know that in the past we had increased in vitro reduced susceptibility to amodiaquine, which were linked to some of the mutation, which are the chloroquine mutation, in fact, chloroquine resistance mutation. But apart of this, we do not really know what is the situation of amodiaquine resistance in Africa. So it's quite important to monitor it. Then I'm jumping to piperaquine, and piperaquine, we have also very limited studies. We have molecular markers for piperaquine, but these have been validated outside Africa, so it's important to validate them. And then we have some studies which combine in some sites DHA piperaquine and artemether-lumefantrine failures in some sites in Africa. But again, this does not make so much sense in terms of biology that parasite would be at the same time resistant to lumefantrine and to piperaquine. And this also needs to be further investigated. And finally, we have the problem of lumefantrine, because artemether-lumefantrine is the ACTs which is the most used in Africa. Over 85% of the ACTs used in Africa in the public sector are based on artemether-lumefantrine. So it's a major problem if we would lose lumefantrine. In addition, the only non-ACT drug which is currently being developed, ganaplacide lumefantrine, has also lumefantrine as one of the partner drugs. So just to summarize, is that we do not have validated molecular markers for lumefantrine. There were since the last 10 years, there were here and there studies showing artemether-lumefantrine treatment failures. There were some concern sometimes about the methodology used or the quality of the microscopy. But despite the fact that we see this treatment failure with artemether-lumefantrine, we are not able, and I hope not, but we need absolutely more study and better studies on artemether-lumefantrine to really confirm if lumefantrine resistance has emerged or not in Africa. And I would like to re-emphasize the problem of lumefantrine in Africa, resistance in Africa. I mean, as I said, TES have highlighted some signals of high treatment failure, but sometimes it was study deviated from the WHO protocol. For lumefantrine, there are many confounders that could lead to artemether-lumefantrine treatment failures. The first one is poor absorption. You all know that RL needs to be given with food, and sometimes this is forgotten. You all know that RL needs to be given in the morning and in the evening, and sometimes the dose, even in therapeutic efficacy studies, are not supervised. So we do not really know in real life if the patients or the parents give the second dose to the children in the evening. And we should not forget that lumefantrine has the shortest half-life of all the partner drugs. And therefore, it's a drug that is really prone to reinfection, which could be, depending on the method you use for PCR correction, could be misclassified as recrudescent. So as you can see, and I reiterate that very more sophisticated studies should be implemented in really to confirm or to inform the presence of lumefantrine resistance. And again, sorry, there are other signals we had reports from IL treatment failures in travelers, which always have been a very good signals of a problem in Africa. I remember the time where we looked for chloroquine resistance in travelers. So there were IL treatment failure reported in people, in travelers coming back to the UK, to Sweden, to Portugal, but the blood levels were not available. So we do not know if it was a problem of absorption or not. But on the other hand, we also have reports where when you have a first treatment with treatment failure with IL, giving a second dose of IL in travels going back to Turkey or to Sri Lanka, the patient was completely cured. So this was not a problem of resistance, but rather from a problem of absorption or insufficient blood level, which allowed with a second dose to cure the patient. We have also heard about reports showing reduced susceptibility in vitro. So there are a set of arguments pro and cons, but finally, there was no high treatment failure rate in Laos or in Myanmar, where artemisinin partial resistance was extremely high. So that's a good sign. This doesn't mean that if you have artemisinin partial resistance, this will automatically lead to lumefantrine resistance. But nevertheless, this is a plea here for better study, which will give us a better insight of the existence or not of lumefantrine resistance in Africa. So just to say that all this information I gave you, if you want more details, you can find additional data on our malaria threat maps on our website. You have here is the link. And just a couple of words, as some of you know, we are developing in collaboration with AFRO a strategy to limit the spread and the development and spread of anti-malaria resistance in Africa. Just to tell you that the first draft of the strategy is online, and I really would value the input of everybody in order to make this strategy a success in terms of what is written in it and how we can implement it. So the strategy, I just have to re-emphasize that we have only ACTs for the time being. 85% is due to IL. We in the Greater Mekong, we had artemisinin partial resistance and partner drug resistance, and Africa is the continent with more than 90% of the global cases. So having a problem with ACTs would be disaster for Africa. Just reiterate that we have artemisinin partial resistance in Uganda, Rwanda, and Horn of Africa, and this will put more pressure on the partner drug. Is a risk, but necessarily will absolutely develop, but it's a risk for the partner drug. So, so we need a strategy in order to prevent the emergence of resistance and to tackle resistance once it has emerged. And the strategy, if you have time to read it and to comment it, and I'm grateful for that, we rely on better use of existing tools and developing new strategy, which can be actioned at the global, regional, and local level. So I'm just, this is one of the last slides. It's just to say that we have 4 pillars. One is strengthening the surveillance. The second is optimizing and better regulating the use and diagnostic of therapeutics to limit drug pressure. The third is react resistance by limiting the spread of anti-malaria drug resistance parasite. And the fourth one is to stimulate research and innovation to better leverage existing tools. These are 20 intervention, but the country, we know that the country cannot implement 20 intervention. So before entering into the strategy, the country need to do an assessment prior to the intervention. And also to say that you need a key enabling mechanism, you need the country ownership, you need financing, you need advocacy, you need regional coordination, and you need very good routine surveillance in order to feed back to the assessment. So this is the last slide, and I thank you for your attention. Thank you very much.
And also what we have been starting also observing in terms of these vectors, it also they are feeding outside and inside. So it led us to try to strategize and also think how we can also try to kill or mosquitoes also, or put some preventive measures which are working outside the house, because mainly the guided intervention are working inside. As you know, we are using mostly LLIN to all, which are using when people are sleeping, and also the indoor residual spraying. In terms of incidents, we have seen over 5 years now a good trend. Malaria are dropping, and this is really the impact of working intervention being deployed countrywide. The prevalence from recent demographic health survey showed that there is a big drop, where we count almost 1% of malaria in children under 5. To reiterate what Dr. Mabel have been shown this morning, these are key national malaria control intervention we are using. Mostly it's in terms of prevention, being bites with mosquito. And here we have added some new tools that are being used, like repellents, to when people are outside gathering before they enter inside the house, because they are using LLIN, and also if they are being sprayed in their house. And for this afternoon session, we'll be focusing on case management, and we have acknowledged that over 60% of malaria cases reported in country are being treated, diagnosed and treated by community health workers, which help us to reduce severe malaria cases and death, in conjunction with SBCC and also new tools. The map here, it comes to show us how we are basing what we are doing on data, and data is very key. It helps us in terms of case management to do quantification of our needs and do quality and efficiency procurement of consumables and drugs we use over a period of a year. And when we are looking on this stratification we are doing now, it goes up to sector level, and as the morning were presented, what we are trying to do now is to go at village level, so it can show us really the real foci and where we could target appropriately different intervention, including the early diagnosis and treatment for all, so no one is left behind. And soon, maybe we arrive at a level of having mosquitoes live with them, but without parasites. And this is the main goal of the malaria program in Rwanda. Coming to the history of anti-malaria drug and how we are doing to know the parasites in circulation and how drugs are working. Historically, we have different sentinel sites which are operational, and starting 1998, at that time we are looking on chloroquine, amodiaquine, SP, but today we are going to focus on the artemether-lumefantrine. In 2004 and 5, the adequate clinical parasite response showed that to this, the AL was efficacious at 96%, and the adoption of this drug were done in 2006, countrywide, and the molecule were used both at community and all the health facility levels. Since 2006 up to date, it's almost 16 years. We have been using AL, and up to date, the ACPR is above 95%. And this have been possible based on different strategies, because in country, when we procure anti-malaria drug or any other commodities, it passes through one entity, which we call today is called Rwanda medical supply. Maybe some here knows that one used to be called like Cameroon. And as it has been channeled in one channel, then distribute over different health facility. And we know that the drug before entering in country, the Rwanda Food Drug Administration Agency give the important license and they check on quality of drug before it enter in country. So we are sure that the quality of drug we are using is optimal. We have the active ingredient which is working, and at least once a year, we do the post-marketing also quality control of drug we are using to check if nothing have been changed during storage or transportation from from the central storage to the lower level, and good enough, up to date, nothing have been observed in terms of substandard. The drug have been qualified to have the international pharmacopoeia required to have the active ingredient and work well. So coming back to the therapeutic efficacy study, over 2 years, the round are being conducted in different sentinel sites we have in country. So normally we do have 6, but depending on availability of funds, there are 3 which are consistently operational, one in the eastern parts, the other one in Kigali Central, and the other one in the southwestern of the country. And as you can see here, we have started to look, all the period have been conducted the therapeutic efficacy study. It shows us the efficacy is above 95%, and starting the year of, sorry, I'm going to take the pointer. These data were collected in 2012-15 up to 2018. We started to look on molecular marker, and these 2 shows us that where we were collecting, and in 2017, we observed that we have the mutant parasite, which were on the list of 10 confirmed mutant parasites by WHO to induce the delay in parasite clearance. And this, since we have received this information, we continuously doing that. And the following year, we observed that in some of the 2 sites, it was like this, the mutant parasites have increased in numbers in those 2 sites, but good enough, the adequate clinical parasite response remain high, and we continue using the same drug. Nothing have changed despite this, but what we are doing in terms of controlling this is to strengthen the intervention we are doing in terms of preventing malaria, treating early as we can, and also using the quality drugs, which we try to control and ensure that everything is done in harmony, and we have people cured. And also in terms of health system, the system of transfer is connected in a way that even if there is a severe cases, it gets to the upper level on time and receive treatments. This morning, we have seen the presentation from Dr. Emab. We have seen that the case is continuously going down, and all this, we thank our leadership as the Sierra Leone was presenting. Here we have this opportunity, because everything we are doing, we have the Rwanda government with Evolve, and they direct us. We do what we do, and we are together. If in terms of getting funds to implement, because what I can tell here is in terms of doing IRS, at the time of 2015, the indoor residual spraying was done only in 5 endemic districts, but today we are doing in 13. So they received this, they saw this, how the impact of IRS was observed and was direct. When you finish to spray in 1 month, you see the case dropped. So they agree even to put in the national basket fund to do IRS in country. So this is how the numbers of districts have increased. Today we are doing in 13 and it is consistent, no delay. That's why you are seeing the impact in what we are doing today. Looking on this meat and parasite we are observing, we have notified like 5 mittens. One is confirmed, what is the 561H, and also the 574. The others are candidates, and also the wild type. But mostly these are observed in Rukara and Masaka. And as of today, the prevalence, this is the numbers of prevalence observed in day 3 parasitemia positive. But what we are doing here, it was based on blood smear counting during the test. We did not look on parasite clearance time or looking on the lumefantrine on 7 days. This is how it was up to date, but the test we are doing now, so as we have been observing this, even though the AL is working well, but it's something, and we have this presence of mutant, it's something we need to be vigilant and don't really trying to slow down the spread of these parasites, and also prevent lumefantrine, the partner drug, also to get this mutation. So what we are doing now in this current tests, which are ongoing, we added some other tests which will be done compared to what we have been doing in routine. We'll be doing the parasite clearance time, so to see really how the artemisinin are clearing the parasite in blood, the in vitro drug sensitivity, molecular markers will be checked to see the resistance, how the density, its proportion, if it's going up or going down, and also to measure lumefantrine level at 7 days, so we know if the partner drugs still work well or if there is something going wrong. So we can take action in time, and this will be also possible because we are also plan to test new ACTs, which is pyridine artesunate, and also with partners and research institution, we are also studying the triple ACT as of now, so which will be like an alternative if something went wrong without delay. So we know that in future coming year, 1 year or 6 months, we'll have an alternative if AL fail or lumefantrine, because up to date we see that the AL is working well despite the presence of that mutation. Other key information we are going to share with you is that we are also discussing, and we are even in a phase of doing procurement of other ACTs, which we are looking how to do multi-first line treatment, so it can help us to overcome this issue of spreading the mutant or delay the lumefantrine resistance. Thank you for your kind attention, and if any question of clarification, please feel free to ask. Thank you.
So thank you very much, Dr. Lin. Pascal, I hope you're still on the line. If that's okay.
I'm here, if you can hear me.
Yes, we can. So, ladies and gentlemen, what we are going to do is we'll take a couple of questions, and in the meantime also, I would like to call upon some NMCPs to join us in our panel discussion. So we will have Dennis from Uganda, from Sinab from Senegal, and I think we are missing DRC, unfortunately, but Rwanda, Dr. Lin will be there. So Uganda, Senegal, NMCP representatives, please join us at the panel. In the meantime, I'll take, if anybody in the audience has a question either for Aline or Pascal, let's take those. So Mahu, let's start with you. And then we'll come to
Yeah, thanks very much. And this is a question for Dr. Ringwald. This is Mehul Doda speaking from Mahidol Oxford Tropical Medicine Research Unit. Thanks very much for a really excellent overview of the resistance situation in Africa. I just want to go back to one of the points that you raised about fitness costs and the fact that, you know, even if artemisinin resistance, partial artemisinin resistance emerges in Africa, it might get lost or diluted out because of the high diversity of the parasites. But what we're seeing in Uganda is that, you know, there is a relatively high transmission over there. But despite that, we are seeing the prevalence of the Kelch mutations increasing year on year over several years. So I was just wondering if you had any thoughts on why that might be happening. Thanks a lot.
Pascal, go ahead.
Yes, yeah, thank you, Mehul, for this question. There are two different issues, in fact. What I was referring to fitness costs are in vitro studies that were conducted by David Fedok at Columbia University, showing that for some of the strains, and this is the whole concept that the background mutation of the parasite is crucial for artemisinin, for anti-malarial drug resistance. What he has shown is that for some parasite, the fitness cost would be higher for African strain than for Asian strains. So that one thing, which could in one way slowing down the transmission, but not entirely. And I fully agree that this needs to be studied case by case. And on the other hand, we clearly show, and I fully agree with you, is that what we see, and despite the extremely high efficacy of the ACTs in all the countries, which are Uganda, Horn of Africa, and Rwanda, we see this parasite spreading. And this is most probably what has been seen in the Greater Mekong, is that this parasite have a greater capacity of developing very early gametocytes. This has been proven with Asian strains in clinical trial that you have conducted, but this needs to be proven also for African strains. And also, I know that research is going on showing that this parasite can be transmitted by mosquitoes. So there are two things. One, the fitness cost that could be a little bit lowering the spread, but limited. And then the other one, which is the increased capacity, which will definitely overcome the fitness cost, which is the capacity of developed gametocytes. On the other hand, as you have seen, for instance, in Guyana, without doing a lot of things and without changing the policy, we saw this parasite disappearing. And this is definitely due to a fitness cost. So at the beginning, they can be transmitted, and then after they can disappear. But I agree with you. Currently, what we see in Uganda, Rwanda, and Horn of Africa is that the capacity of transmitting is higher than the fitness cost. Over.
Thank you, Pascal. There was another question over there. Go ahead.
My question, can you hear me? My question is to Aline, and I have 3 questions or so. The first observation was, you mentioned that you are seeing a varying epidemiology for your malaria, the causing species. And while initially we've assumed PF, now we're seeing PM, PO. I'm guessing first that's co-infection. But my actual question is, do you think that this represents an evolution in how, in malaria? And is this something you're going to be checking going forward to see if the other species are actually now becoming more important? We know that they're probably not responsible for severe disease, but they'll be responsible for uncomplicated mostly. So that's question 1. And then question 2, you mentioned testing artesunate pyranidine and TACT. Are you talking about this in the context of therapeutic efficacy studies? Would you add them to the current platform? Or are you doing additional studies as Rwanda? And I'm aware that in some countries, before a drug is introduced, it's put on therapeutic efficacy studies. And then my final question is about the single low-dose Primaquine. And again, because I seem to get the impression that this was more important where you had really low transmission, where now we had few people who are asymptomatic carriers. So Is this going to be rolled out uniformly, or is it going to target areas where you think that the cases are the sources of gametocytes? Thank you.
And Dr. Lin, you can go ahead and answer. In the meantime, if other questions come, we'll take them and answer them as we go. Dr. Lin.
Thank you for the good question. Let me start on this regarding species. As I mentioned, we have started seeing change in variation in distribution of species, and mostly, as you have indicated, the ovale or malaria are being, most of the time, is a mixed infection with falciparum, and good enough as we are treating those people, and we see that there is no failure, if I can say it like that, even though when we are treating in normal case management, we don't do the follow-up like we are doing for tests. And what we do is to continue doing operational research and see how these species are being increased or changing in terms of increase in some or decrease in the other. And what we do is to have an eye on that and know if anything happen, so we can change. Because as you may know, the treatment for ovale, it's another one which is not AL, but as we are still in phase of controlling, and we are giving this AL and it works well. So we are still doing that, except if we have in higher numbers, so we can change and look at that. And also maybe have a chance of adding the single dose primaquine for preventing relapse. And this is, as you have saying, let me jump in on the third question where we're asking how we are looking to add the single dose of primaquine in treatment. And yes, of course, as you have seen the map we have, so it will be deployed based on the incidence and see really some districts where we may use that, and others we continue with other treatments. And the idea and what we are planning to do is to introduce the single low dose of primaquine in some districts based on the incidence, and other districts we use other first-line treatments. And of course, what we are targeting is to use the DHA piperaquine as is one of the ACT which have been studied in country, and we know it as its efficacy at higher level. So this is the two. Soon, starting 2023, as we have started planning the quantification and procurement process, it's something which will be introduced and see how it changes. So as Pascal was presenting in some Guyana or Lao, their experience, so I thought about the DHA piperaquine, what happened in one of the country he presented, because maybe, I don't know, maybe they installed that one where the lumefantrine have get the resistance stage. So this test we are doing will give us the picture of how the lumefantrine is working today in country. Then it can orient us to take the decision and implement that. Or if it's already not working well, so that option will be dropped and look for another alternative. As we are studying also the Pyramax and the DTAC, maybe the result will be out and we'll have those fundings, and we may choose between those 2 or 3 or all of them, then see how we target districts based on different settings we have and locality. And also, as you know, to do all this, it's something which is very demanding. There is time and also training, guidelines, tools, and also the key of this is the supply chain. So how we are looking to do this, it will be done alternatively from district to others, so we don't mix. And also when we are moving, as Pascal was saying, we move with all the commodities, so we are not mixing. And so we look if we can have a good result. Thank you.
Thank you, Dr. Aline. And just to add on to the primaquine, yes, it's true, it's for low density places or low transmission, but because Rwanda has also maybe seen the parasites with the mutation, one way to reduce the transmission of that is also to target those places where you actually see where the, like Masaka or Rukara, that could also be a way to stop the transmission of those mutant parasites. But anyway, so let me go back to the panel now. So thank you, Senegal and Uganda and Rwanda for joining us. So I think my first question I just want to go straight to Uganda, first of all, because you did not get a chance to present something from your country. And Pascal and everybody has been talking about Uganda, the Horn of Africa and Uganda. So and Rwanda. So I want to give you an opportunity, Dennis, to just tell us a little bit about what's going on in Uganda. We've read some papers, we've heard a few things. So just give us an overview of what are you seeing in Uganda, concerning drug resistance.
Hey, thanks very much. I know most of you must have read or heard about Uganda, particularly currently we have upsurges, unlike Rwanda, and I think that's why you are here to learn a lot, because we neighbor Rwanda, and I think we should be at the same level. We wouldn't like to continue exporting malaria to Rwanda. We have upsurges, of course. I may not attribute it to the resistance they are talking about. There are many factors, and currently there are experts, I think, in-country experts trying to review what could have gone wrong, because we have about 70, it's more than 50% of the country has malaria upsurges, and others are in epidemic level. As what Pascal represented, of course, they had just mutant parasites, particularly, I think a study was done, but what also we just saw it in the journal, and some researchers do without our involvement. Of course, at first we do not agree, but later on it was proved to us it's true that about 5.8% of the treatment failures had the K13 mutant gene. Not that withstanding, we, of course, like Rwanda, we have been doing drug therapy studies where we are involved, and there's an institution which usually we work together, that is infectious disease research collaboration, and I think the recent one was 2014, and another recent was 2019, 2020. And of course, there were some signs of air treatment failure. So I can particularly comment on the recent one, which was 2019, 2020. We have 5 sites which are not representative. Rwanda, I think, also had 5, but compared to the size of Uganda, we should be having at least minimum 10. And at one site, I think the AR was 89% efficacy. That's failed 11%. But through discussions and that the statistical analysis, they used the CDC and like having used WHO. So even some of the results are not yet disseminated. So there were experts sat and they recommended, like currently, we have to do another test, particularly including now, we have AR, ASAC, that is artesunate DP. We have been studying those 3 molecules, and currently we have to include also pardon artesunate, which is in the country on the co-payment maker in the private sector, but in the public sector we have not included it because we had first studied it, and we shall decide whether to use the second line, and so we are going to study AR, ASAC, DP, and pardon artesunate. So from that, we shall choose which should be the first line, because there are glaring signs that AR efficacy is reducing in the country, maybe because of that mutation. So up to now, our AR is the first line, and we have not yet changed the policy, still the first line. And from the presentations of Rwanda, and Pasco said, having delayed clearance of artemisinin does not mean treatment failure. But what I could say that, you know, AR, I had case management, and we have guidelines. Like AR, we are supposed to give time 0 after 8 hours, then 12 hours. But incidentally, most practitioners give it BD, 12 hours, 12 hours. So some of we may say there's treatment failure when the dose was not properly taken. And of course, the challenges of private sector. As I said, about 60% of our patients first go to private sector. Control of private sector is still challenging, where sometimes those small drug shops, particularly, can even issue underdose. And you know what it means. But the country, we are trying to work in it with regulators, and also, as I say, we have to do particular mentorships, both in public and private sector, and we hope the situation will improve. But we can't think of changing the policy now until we have done our therapeutic studies, which is planned at the end of the year or next year, depending on the funding. But we have upsurges, and okay, we are talking of suspectable, delayed artemisinin resistance, but also there are other interventions which may have contributed to upsurges. The indoor residual spraying, I was to ask Imabre that what chemical do they use for IRS, because currently we are using Frodora fusion, and people, other countries say it's effective, but the residual effect for Frodora, we're proving it to be less than 4 months, and where it has been sprayed, maybe our parasites, our mosquitoes are different, we can't tell. So even we are planning to change the chemical, because the 2 rounds where they have sprayed, minimal impact, and of course that can explain the upsurges. Second, most of the malaria interventions, we are donor dependent, and some like PMIs, partner support, I think delayed for almost 2 years, and they were supporting about 2/5 of the country. So some of the, and the support group fund, when you are writing a concept note, you say, what is a gap? Because PMI had promised to cater for this, but it delayed. So all those could have contributed to the upsurges. But what Pasco presented is truth, and there are other small studies which also point out that is delayed artemisinin resistance, and K13 mutation gene is present. So we are to learn and see how to minimize the spread of that mutant parasite. However, so let's wait for the therapeutic study where we are to include palinoteson, and we shall decide. Thank you.
Mm-hmm. Thank you so much, Dennis. Yeah, you actually mentioned 2 things that caught my eyes. One is the collaboration, or at least letting NMCPs know the good research that's happening in the country. Because if we are publishing all these great papers and the NMCP is not aware, that's really a sad thing. So I think it behooves all of us who are in research or in other institutions to really keep the NMCP, especially in these that could be policy changing kind of results. So I thought it was nice that you highlighted that sometimes gap in communication. But also you mentioned about just finding the markers doesn't mean that the drugs are failing, which is also something that Pascal mentioned. So that's very important that we keep that in mind. So thank you. I want to go to Senegal, and Senegal is great at doing TESs, or at least we've seen this, and we just want, if you can share with all of us here how you do your TESs, because I know you do them often and you get good data and a lot of other many things, components that you do into your TESs. So if you can share your experiences with the rest of us on conducting TESs in Senegal.
Okay. Thank you so much. In Senegal, we have a consortium leading by PMI, funding by PMI, and NMCP work closely with University Cheikh Anta Diop with researchers, and TRAF, the International Center for Research and Training Applied in Genomics and Surveillance. It is a new center in Dakar. We regularly conduct studies for drug resistance, and we do therapeutic efficacy studies and also molecular marker surveillance. And with these studies, we use the WHO 2009 protocol, and we have at this time safety for the drug we use, because in all the country we do the monitoring for artesunate amodiaquine, dihydroartemisinin piperacin, and artemether lumefantrine 2. And we do also the monitoring for SP, because we use SP in SMC and also for pregnant women, and we need to assure that we use the use is safe. And for this, the result of these studies have shown an effectiveness of rate of the molecule use, and in exception in one zone in the country, it is in the southeast in the country, where the incidence is very higher in the country. And in this area, we noticed that for DHAPQ, for an effectiveness at 100% for all molecule except DHAPQ, we are around 97%, and amodiaquine, artemether, we are around 98-99%. And the conclusion of the study says that the antimalarials in Senegal remain effective, but we need to continue monitoring, because even in some country in Burkina Faso, which is not far from Senegal, we notice some resistance, and we need to improve the surveillance to be aware of and prevent the drug resistance. Thank you.
Thank you. So I'm checking the time here. So because I would want to also give the audience a chance, but one question for Dr. Lin. So through you have documented partial resistance, you've also documented delayed clearance, and you've given us a list of some of the things that you're doing. So if you can just recap those, because I think for most of us here, we are wondering, what should we be doing? What should NMCPs be doing right now to prevent? Because we can't just sit and wait for it to happen. So you are among the first countries that are seeing this. So what can you tell the rest of us, NMCPs in different countries, to start prepping or start doing just as, what should we be doing? Is really my question. And then after that, I'll open it up to the rest of the people. Dr. Lin.
Okay. Thank you, Naomi. So if I do a recap of what we have been discussing since morning up to now, so what we should be doing really is to be vigilant in what we are doing, And remember all the time, each intervention we are going to put in place need to be evidence-based. We prioritize to do operational research in any intervention we are doing. Then if we observe any issue, then the findings of this study, we are looking in monitoring or surveillance of the impact of activities we are implementing, so the action is taken on time. And we ensure that no one is left behind. So you remember this morning, there are even special target group Dr. Emabla has mentioned, like those people who are guardians, staying outside. So we make sure when we are planning, we have also preventive measures which are appropriate for them. And also we ensure that, let's say, for example, for the topic we are talking right now, the case management. So the key important tool we need to have is to have on hand quality drugs. And most of this is where if we are using substandard anti-malaria drug, so you are letting people not getting cured, is the gametocytes remain in blood circulating, so the cycle is not cut. And to make this happen, so we need to do regular checks. And as I said just before, we have regulation in place. We know who is buying where and when and at which costs. Because remember, the cost is very critical. If a patient doesn't have money to pay drug, he will not afford, and what happened later is death. So, and what we have tried to do here in country with the support of the government is to have accessible drug. And as it has been said morning by Dr. Emab, all simple malaria are treated at lower level. So 90% of cases reported in country are being diagnosed and treated at a level of community health workers and the health center and health posts. And also we make sure that we have all those diagnostic tools and treatments. And again, we do monitor, and we have put many systems in place. For example, for community health workers, if they have stock out, they have a system which called rapid SMS. They can send an SMS to the in charge of community health workers. The SMS is received even up to the central level, so you can even call and check if she or he have been resupplied. So to try to make sure that they do have commodity, then they treat on time. And that's why we have achieved to treat over 95% of people are treated at community level, are being treated on offset of sign and symptom, because they live with those binom who are treating in their villages. So without taking long, mostly we put emphasis on what we are doing, and we make sure everything is guided on data. Thank you.
Yeah, thank you, Dr. Lane. And for the drug resistance, I know you mentioned about the multi-first line treatment that you're thinking about, introduction of new molecules like Paramax and Primaquine for reduction of gametocytes and so on. So now, anybody in the audience who has a question for the panelists? Okay, the back.
Thank you very much. I have two questions. The first one is to Pascal. A lot of us are stuck with SP for a lot of our chemo prevention or chemoprophylaxis interventions. But there are reports of SP resistance in quite a number of areas, but we still go ahead and use it. My question is, at what point or at what level of resistance should countries consider an alternative for SP? Yeah, that's my first question. And then my second question is to the panelists. A lot of Africans use herbal medicines. And I don't know, do you have it as part of your treatment regimen? And if you do you have any report of running an efficacy study on some of these herbal medicines? Thank you.
Okay, herbal medicines, you know, non-conventional. Yeah. So Pascal, if you're still on the line.
I'm there.
Okay, go ahead.
Okay, yeah, thank you for the question about SP. You're absolutely right. SP is not used anymore for the treatment of uncomplicated malaria because of widespread of SP resistance, which is well documented by the molecular marker, DHFR, DHPS, etc. Now, the question you're asking is not for treatment, but for prophylaxis. And it's given either in IPTI or in children in combination with amidaquine. And here we are not looking for the effect of treatment, but we are looking for the effect of avoiding an infection of malaria. And maybe despite resistance, the drug still has a good efficacy in terms of having a prophylactic effect. When do we need to stop using it? This is exactly the purpose of the protocol that we are going to put online very soon, which is quite different from the therapeutic efficacy studies, which will allow to at the same time monitor the prophylactic effect of a drug and at the same time trying to correlate it with the presence of marker of resistance or not. So to answer your question, you are right for raising the question, and thank you for that. When do we need to change? I don't know, because the data are a little bit discordant of when SP has still an prophylactic effect or not. We all agree it has no more therapeutic effect. Still, you could imagine that extremely low parasitemia could be killed by SP, and you could also imagine that SP could have a prophylactic effect. But the whole purpose of the protocol is now to look the correlation between molecular markers and the prophylactic effect. Though this should not stop researcher or programs, national programs, to start looking for alternative, comparing with SP or doing it alone. And I know that there are many studies for many different groups at risk. And many studies have already looked at alternatives, either with ACTs or SP in combination with amidaquine, or in the past we even tried chloroquine with azithromycin. So a new option and study monitoring new option are welcome. Over.
Okay, thank you, Pascal. So our panelists, so the question was herbal usage of, as anti-malarials. So I'll start with Dennis, then Zainab and Aline.
Yeah, thanks very much. I think in most parts of Africa, they use some herb medicine for one situation or another. But for Uganda, the herbal medicine, we don't have any in our guidelines. But what I know, there is a department which oversees those herbal small research, and it's linked to National Drug Authority. Though we don't have it in our national guidelines, we know some patients first go take herbal medicine at community level. And that's why sometimes come when they already have severe malaria, and they report they have taken herbal medicine. So it's something which we need maybe to also strengthen collaboration with that section, overseeing that, and see whether it's true there are some herbal medicine which can treat malaria. But we have got severe malaria cases in health facilities, and the report is that they first take some herbal medicine. It's not in our guidelines.
Zainab. So 1 minute just to answer that.
I think it's quite the same in Senegal, but we have a big threat in Senegal. It is the use of Artemisia. Artemisia amnia, because we have some field with Artemisia, and they do the promotion like it is very good for malaria. And I think with COVID-19, we have a very big problem, because they say the Artemisia can treat COVID, and we have a large use of Artemisia in this time, I think the CIGAS, the Genomics Center, is doing some studies to see if there is an impact on the malaria treatment. But in our guidelines, it is clear we don't use Artemisia because it is prohibited. And even for community health workers, when we do training, we do many sensitization to talk to the population to not use this kind of medicine because it can develop resistance at the end. Thank you.
Dr. Lin.
Thank you. As my predecessor says, the herbal medicine is not part of the malaria treatment guideline. We don't use that. But again, we have at Ministry of Health a division unit which regulates traditional healer, and they try to include them in the system. So what they do and try to give them some training on what they can cure and not, so they can transfer those people come with sinus fever on time to go to the nearest community health workers before if they have suspected malaria cases, so there is no delay in terms of receiving adequate care at appropriate point of care and also being treated. But despite in some places, it used to be a long time ago, as Dennis has mentioned, people could pass before to those traditional healers before they go to seek treatment at upper level. So now, as they do have community health workers in their villages, they do sensitize them, they tell them different signs of malaria, and we work in collaboration with leader administrative community, and also we have now a big number of civil society organizations which are dealing, putting much sensitization and effort in terms of social behavior change communication. So they keep reminding people in their villages, and also part of that they include also the IVM, so they can try to overcome this issue of malaria transmission, and specifically puts much emphasis to seek treatment on the appropriate level of care instead of going seek this take kind of herbal medicine. So at the end, you may end up having severe malaria and death or cure due to delay of consultation. Over.
Mm-hmm. Thank you. Michael, you have one last question, so yes. Go ahead.
A very quick one. This question goes to Pascal or WHO, just for guidance. I was recently advised that the TIS, you can only do one arm. It's not really recommended to do 2 arms, but I think it's been a tradition in most countries where we always do 2 arms or 3 arms or multiple arms. I just wanted to be advised which one is the right one, the recommended one, because I was told you could do just 1 arm and try to have more sites or a bigger sample size than having multiple arms where you spend more on following up patients. Secondly, the injectable artesunate. I was once asked, how do you monitor the efficacy of injectable artesunate? We had a case in one of the referral hospital where a young boy was not responding to an injectable artesunate. They checked the parasites, they were still there after more than 4 days of injectable artesunate treatment. And then they looked for quinine. When they started quinine, this child was saved and the parasites cleared. And then they were asking me, how do you monitor the efficacy of injectable artesunate? And unfortunately, I just said, I'll come back, let me consult. So I'm not sure whether I could get any guidance as to how we monitor the injectable artesunate, or we just assume that it's fine. Thank you.
Okay, so Pascal, over to you, or if not Pascal, I don't want to say Peter because he's been in trouble.
Okay. No, I'm here. So, no, the recommendation in terms of surveillance, basic surveillance, is to do one drug at the time. And if you can, you can do even during the season, several drugs one after the other sequentially. The problem is that you can do multiple arms and trying to compare, but the sample size would be, if you want to show the superiority or even the non-inferiority of one drug to another, you would need much more patients. So this will increase the number of patients if you do a comparative trial, even in a non-inferiority. What's happened, what I see in the past, but this is not, I cannot generalize it, is that in some cases, the country tried to do a comparative trial, and at the end, the transmission season stopped, and they were able only to include 30 patients per arm, and then this was not significant, and they could not reach their goal. Whereas doing just one drug, and then the other drug next year, they would have more conclusive data. So again, no restriction, but just bear in mind what can be feasible. Look at the constraints of doing multiple arms compared to doing single arms or doing it one after the other, etc. Everything needs to be weighted and which is the more appropriate. But again, in terms of basic surveillance, and this was recommended once during a treatment guideline committee, it was recommended to do only one arm. Monitoring artesunate, if you want to monitor artesunate monotherapy or injectables, you would need to monitor over 7 days, but this is not the recommendation. We do not recommend to do injectable 7 days with artesunate, because as soon as possible, the patient needs to be treated with an ACTs. And this is also something that the country needs to look at if they want to fight against artemisinin partial resistance. Because what we discovered is that most often people receive injectables or rectal artesunate and do not complete the full treatment of ACTs. Now, I cannot comment on the case that was reported that after 4 days, but I have seen similar cases, and sometimes it was also due to the fact that the artesunate was not well diluted or left in the light or maybe prepared in advance, and then artesunate can degrade very quickly. So you need really to look, but what you did is fine. You changed to quinine, which is also an option, and I hope that the patient was successfully treated. But it's quite difficult to monitor injectable artesunate because the policy clearly said that as soon as the patient can swallow, you need to give an ACTs and not to continue 7 days of injectable artesunate. So quite difficult to monitor. Over.
Thank you, Pascal. So everybody, thank you so much for staying it out till it's 5:30 now. It's been such a great pleasure to have our panelists, Dr. Lin, Pascal, thank you for your presentation. So we thank you for your time. So at this point, Larry, if you can just give us the last closing remarks until tomorrow.
Yeah, thank you, Naomi, and thank you to our panelists. I think we've had some really great sessions today. I'm very happy to be sharing this information. For tomorrow, the field trip, please, if you're going on the field trip, please be in the front of the hotel at 7:30. Have your breakfast before. We will be back in time for lunch, so you'll have your lunch here. We have 3 buses, courtesy of Impact Malaria. And we will likely have 1 bus for French speakers, and we'll have 2 buses for English speakers or people who can speak both languages. And that way we'll be able to communicate well, because the CHWs in particular will probably only speak Kinyarwanda, and so we'll need to translate. And we don't have the setup here for translation, so but meet us downstairs at 7:30, and we will direct you to the buses. So I think with that, I think we'll see you tomorrow, and we look forward to the field trip. So. Thanks very much.